Okay, so a malingering, you deliberately induces a symptoms. Okay, although you're not having any symptom, you just made the symptoms, right? Like the abdominal pain, or like you're having a headache, or something like that. So symptoms in this case are intentional. Okay, you deliberately made the symptoms, and the motivation is also intentional. It is often to gain, something like insurance or to avoid work, like the children made their excuses like they're having a pain in the abdomen in order to avoid their schools. Okay, you call it a malingering. Okay, that is the important thing. So patients consciously fakes, profoundly exaggerates, or claim to have a disorder uh, in order to attain a specific gain, right? And they have a poor compliance with the treatment or the follow-up. Okay, and their complaint often ceases up after they gain something, right? After they gain that insurance claim, or after they successfully avoided going to school, their complaints are generally ceased, right? You call it a malingering. Any doubt?
No, thank you.
Then you have factitious disorder. Okay, in factitious disorder, you again made your symptoms. Okay, either you just tell that you're having symptoms although you're not having symptoms at all, or you do have symptoms which are deliberately induced. Okay, but the motivation are is kind of unconscious in this case. Okay, the patient itself do not know why they're doing it. They're just kind of enjoying being a patient, enjoying being hospitalized, enjoying being ill sometimes, right? So symptoms are intentional, but the motivations is unconscious. Okay, they consciously creates a physical or a psychological symptom to assume a sick role. Okay, sometimes they take all the diabetic therapies to get a hypoglycemia, and then they get admitted into the hospital. They eat pills for the hypothyroidism to get a hyperthyroidism, so that they will have this all the anxiety, tremors, sweating, so that they can go into the hospital, right? They may take some diuretic pills to get the dehydration, so that they again go into the hospital, right? So basically they can do anything, okay, to assume the sick role. Okay, they deliberately cause injury to them. Okay, they got multiple scratches and infect them with something else, so that they can get abscess on the hands. Okay, and the patient always have multiple hospital visits, okay, for the same kind of infection or same kind of a thing. Okay, that is an important thing. The patient will have a multiple visits on the hospital over the same symptoms. Okay, that is important, and they won't tell you that they're using a pill, or they do or they kind of injured themselves, right? They won't tell you this. You have to figure it out by looking for the symptoms of the patient, by looking for the labs of the patient. Okay, by looking for the hints. Okay, then it is of two types. It is a factitious disorder imposed on self. Okay, the patient induces the symptoms on themselves by eating some pills or by injuring themselves, right? They so formally it is known as a syndrome. Okay, Musician syndrome. It is a chronic factitious disorder with primarily physical signs and symptoms characterized by a history of multiple hospital admissions and willingness to go to undergo the invasive procedures. It is more common in the women and the healthcare workers. It could be a nurse, it could be a doctor, or a former physician. Okay, most commonly these kind of patients they will be. Then comes the factitious disorder, which is imposed on the other, and it is the proxy, you can say. Emission syndrome by the proxy, you can say. Okay. In this case, instead of inducing symptoms on themselves, okay, patient induces symptoms on their relatives, on their child, okay, or their elderly person. Okay. So illness in a child or an elderly patient is caused or fabricated by the caregiver. Okay, they can give them some pills that can cause the dehydration or diarrhea, or maybe something else like the hypoglycemia in the child. Okay, so basically it is a type of child or elder abuse, you can say. It is a form of child or elder abuse. So whenever you encounter a patient who is having a multiple hospital visits over a same symptom, same type of symptom, okay, and the history they are giving you is not matching with the presentation of the disease, or the labs are not supporting their history, then you can immediately know that the patient is having a factitious disorder. For example, you encounter a patient having a hypoglycemia. So you might think that it could be because of a tumor of of an insulin secreting tumor. It could be. Then you check for the C peptide levels and you find out that the C peptide level are absolutely normal. That means the patient has taken some anti-diabetic pills, and that causes the hypoglycemia, but the patient was not telling you this, and that means it is a factitious disorder. Patient can have a multiple hospital visits over the same symptoms, over the same hypoglycemia. Okay, so you would know that the patient is having a factitious disorder. Any doubt?
No, thank you.
Now you have the somatic symptom disorder, in which you do have the symptoms. Okay, the motivation is unconscious, the symptoms are unconscious. Okay, actually you're not having some, the patient is not having symptoms, but they think that they're having the symptoms. Okay, so first you have the somatic symptom disorder. Okay, in which the patient has a one bodily complaint. It could be a abdominal pain, it could be fatigue, it could be nausea, it could be headache. It's all in their mind. Okay, and when you do the test for the headache, the MRI will be normal, the CT will be normal, the pressure will be normal, the CSF will be normal. Okay, all the labs showing absolutely normal. When you check for any abdominal pain and you run for the test, all the tests will be negative. They might and they might complain of a chest pain that can mimic a heart attack, but all the labs are absolutely normal. Okay, and all their symptoms, they may lasting for like months to years. They can have a history of diarrhea for months or years, but all the labs are showing absolutely normal. Okay, so that's how you know that the patient is having a somatic symptom disorder. They have excessive thoughts about that symptom. They have anxiety about their symptoms, that that no one can treat their symptom, or they and they can never get any help for their symptom. Okay, and they might die from their symptoms. So they have anxiety about their symptoms. Okay, treatment is nothing but you might you offer them a regular office visits. Okay, initially you give them some kind of a therapy which is non-harmful to the patient. Okay, and you tell them to visit regularly. You will make sure you will assure the patient that their symptom has been resolved. Okay, and then you will give them the psychotherapy, and eventually at the time of treatment you will confront them. Then all their symptoms are in their mind only, not a physical not due to any kind of a problem, right? But all the symptoms are in their mind only. So initially you will just offer them the regular office visits, and you will give them the psychotherapy, and eventually you will confront them. Then they're having the symptoms in their mind only, uh, not due to any kind of a problem. Okay, that was about the somatic symptom disorder. Any doubt?
No, thank you.
Then you have the conversion disorder. In this disorder, you will have a neuropathic symptoms. Patient can have a paralysis, patient can have a sensory loss, but it's all in their mind only. Okay, when you run for the test, every test will be normal. Their CT, MRI again will be normal. Okay, and when you check for the reflexes will be absolutely normal. Okay, so a patient, and the conversion, the disorder patient, they always have some kind of a emotional trauma, and after that emotional trauma, they started having this the neuropathic symptoms. Okay, and that is important. And patient are kind of unconcerned about their symptoms, although they're having a paralysis, but they don't feel concerned about it. Okay, you find that patients are absolutely normal. Okay, they don't have any problem with that type of thing, but that but they tell you that they're having this problem, they're having this heaviness in their arms, or they cannot move their arms, or they cannot feel anything with their arms, something like that. Okay, but when you run uh, all the examinations and all the tests, everything came out to be normal. This is the conversion disorder. And then you have the illness anxiety disorder. You do not have any symptom. Okay, you do not okay, and you have no cause for it. Okay, but it just the patient is preoccupied with acquiring or having a serious illness. Even a normal GI sound, okay, it's like they will even with a normal GI sound, they will think that this sound might be due to any cancer in them. If they have a normal abdominal pain, they will think that it might be a cancer. Okay, if they have a normal chest pain, sometimes due to any fatigue or due to any injury, they will think that it could be due to the myocardial infarction or something like that. So they're preoccupied with having a illness, a serious illness. Okay, the physician will run all the tests, and all the tests again came out to be negative. Okay, treatment is nothing but the reassurance. Okay, patient, they do not have any symptoms. That is the important thing, and that's why we'll differentiate with the somatic symptom disorder. Patient has no symptom. Okay, even a slight kind of this abdominal pain or abdominal sound will appear them to be having a cancer. Okay, so patient will repeatedly screen themselves for the signs and symptoms, like they measure their pulse regularly, they measure their blood glucose level, this they regularly, or certain enzymes that might think that they're having this cancer. Okay, so they will always undergo some screening processes. Okay, that was about the illness anxiety disorder. As the name suggests, patient is having a anxiety about having a serious illness. Although they do not have any kind of illness, even a slight symptom will make them very anxious about having a serious illness. Any doubt?
No, thank you.
Okay, so any doubt on this page so far? Anyone please ask, or anything you want me to repeat again? No?
No, thank you.
I actually had
Yeah.
one. I'm so confused between avoidant and social anxiety.
Avoidant and
Social anxiety disorder?
social anxiety disorder. Okay, in the avoidant anxiety disorder, the patient are avoiding the social situations because of a fear of abandonment, or they're avoiding relationships because of a fear of abandonment, because of a fear of this kind of this rejection or inadequacy or feeling of judge. In case of social, and although they always fantasize about having a relationship, having a romantic relationship, but this cannot enter into it because of a feeling of inadequacy, that they're kind of inadequate for their partner. Okay, they think like that, they think like they are very much inferior to others. While in case of my social anxiety disorder, patient is avoiding the social situations because of a fear of embarrassment, that they're different from others, that they might embarrass if they talk to others. Okay,
Okay.
the
Okay.
main thing is about having a relationship. They cannot have a relationship because of fear of inadequacy, abandonment, or or this judge or rejection. In case of social anxiety disorder, they're avoiding all the social situations because of embarrassment, just the embarrassment only. While in avoidant, they have multiple reasons you can think.
All right. Thank you.
Okay, any more doubt on this page?
No, thank you.
Okay. Now let's discuss the eating disorders. The first we have is the anorexia nervosa. Okay, you will always have to differentiate between the anorexia nervosa and the bulimia nervosa. And the important thing to differentiate between them is to look for the BMI of the patient. In both the disorders, the patient is restricting their diet. Okay, they are kind of dieting, they're losing their weight. Okay, they're fasting. Okay, but the main thing is that in case of bulimia nervosa, patient will have a normal BMI which is more than 18. In case of my anorexia nervosa, their BMI is always less. Their BMI is always less than 18. So look for the BMI first. If it is more than 18, think about the bulimia. If it is less than 18, think about the anorexia. Okay, they have an intense. In case of anorexia nervosa, they have an intense fear of weight gain, and that's why they do over fasting. Okay, they will over evaluation of the thinness. They have some kind of a body dysmorphic image thing, but it is very distinct to the body dysmorphic image disorder, right? In case of my body dysmorphic image disorder, they're preoccupied with having one defect only. Okay, in case of my anorexia nervosa, they think that they're having this kind of a defect. They think that they are overweighted even though they are having a very low BMI. Okay, so they will do the caloric restriction. A severe weight loss will happen. Okay, and it will result in the inappropriately low body weight. Okay, it is of two types. One is the binge eating purging type, and second is the restricted type. In binge eating purging, patient will eat food at a time. Okay, and then they feel very guilt about eating it. Okay, and then they start in the purging behavior. They will do vomiting, they will do diuresis, they will induce diarrhea in them. Okay, so that they can lose the weight. Okay, so patient will have a recurrent purging behaviors in it. Okay, they will use laxatives to get the diarrhea. They will use the diuretic pills to get a diuresis. They will induce the vomiting in that case. Okay, or they will have a binge eating over the last 3 months. So if a patient is having a history of binge eating over the last 3 months along with the purging behavior, think about the anorexia nervosa if they have a BMI less than 18. Okay, then comes the restricted type. In the restricted type, they do not have any history of binge eating in the last 3 months. That is important thing. Although they will have the history of purging behavior, the self-induced vomiting, sometimes diuresis, or taking the hypothyroidism pill. Okay, there's thyroid supplements to cause the hyperthyroidism so that they can lose the weight. Okay, they will exercise regularly and exercise too much. Okay, so that their body their BMI is less than 18. So no history of any binge eating, just a history of losing weight, doing multiple activities like gymnastics, exercise, running, weightlifting, and all these things to get a low body weight. So the complications can be the osteoporosis. Why? Because of exercise excessively and having a low body weight in the BMI. Okay, their a hypothalamic pituitary gonadal axis is disrupted, and as a result they will have a loss of GnRH infusions, and as a result they will have a low FSH LH, and as a result a low estrogen. And because of this low estrogen, patient will have a amenorrhea. It would be a teen patient, okay, who had this menorrhagia at the age of like uh, 13 or 14, but at the age of 18 they have this menopause, something like that. Okay, they begin having irregular menses at the age of 18, and then for the last 3 or 4 months they do not have any menses, any cycle, right? You think about the decrease in the estrogen. In that case, patient can also have the osteoporosis. Okay, because of a low protein in their diet, they will have the hair loss. Okay, they can get the parotid hypertrophy. So the level of the slide, all the amylases will rise. Okay, patient, because of low protein, low energy, they will have a low BP and a low heart rate because of loss of the cardiac muscles. They can also have the arrhythmia. Okay, patient can also drink too much water in order to lose the weight, because drinking water can lose your weight. So they will excessively drink water, and that can cause the hyponatremia. Okay, because of a free water loss, they can have a low GFR also, and that will decreases the creatinine levels in their body. Okay, and the creatinine levels also decrease because of a low body mass, because the creatinine is nothing but just a waste product of the muscles, right?
Yeah.
So because of having a low muscle mass, they will have a low creatinine value. Okay, their bone marrow can also be get suppressed, and as a result they can also get the pancytopenia. They will have a very specific thing which is not found in the bulimia other than the BMI, is the lanugo body hair. They will have a very fine soft hair all over their body, like a baby. Okay, if you ever feel the hairs of a baby, they're very soft, very fine. Okay, fluffy. That kind of a hair will be seen in the lanugo hair growth in these patients. Okay, because of the malnutrition, they can have a depression, they can have a constipation, they can also have a decrease in the concentration. Okay, so the features are less than 18 BMI, body image disturbances. Even a normal BMI seems to be too much for them. Okay, symptoms include the restrictive eating, binge eating, and purging. Subtypes include the restrictive eating, in which patient have no binge eating history for the last 3 months. Okay, they will have a weight loss which is achieved by the excessive dieting and the exercise, and sometimes vomiting also. In case of binge eating or purging type, they will have a history of binge eating in the last 3 months for more than 1 week, and they will feel very guilty about excessive eating, and then they have a purging behavior in which they use the laxatives, diuretics. They will do self-induced vomiting. They will have excessive of water that can lead to the hyponatremia. Additional features, please remember, they are low of everything. Everything is low in them. In the CNS, they can have a hypothermia. Okay, they can have a seizures. In the endocrine, they can have a amenorrhea because of inhibition of the HPG axis, hypothalamic pituitary gonadal axis. They will have a loss of thyroid. They can have a hypothyroidism. Adrenal mass will be decreased. They will have an increase in the stress hormone because their body is in stress right now. In the CVS, they can have a bradycardia, low heart rate, low BP. In the bones, they can have, because of low estrogen, they can have a low they can have a osteoporosis. Skin and hair, their skin will, because of the hypothyroidism, their skin will become very dry and cool, and they will have a lanuco body hair. Okay, they can you can also find the rash on the knuckles because of the vomiting, because of a self-induced vomiting. Okay, they can have these kind of a rash on the knuckles because they will put their hand into their mouth to cause a gag and to cause the vomiting, right? So they can get a rash over their knuckles because of the vomiting. Their amylin in the teeth, it can get destroyed. Sorry, not the amylin, but the enamel in the teeth can get destroyed. Okay, so you will get a dental caries because of the acid in their mouth. Okay, just like okay, similar cases, you will get a dental caries, you will get the enamel erosion. In the salivary glands, patient can have a high amylase because of the parotid hypertrophy. So what labs you must do in the patients? First of all, whenever you encounter such kind of a patient having a low body weight, okay, you will first run the electrolytes, and you will note that all the electrolytes in their body is very much low. Okay, except they will have a very high bicarbonate level. So they are having a metabolic alkalosis. And why high bicarbonate?
Vomiting.
Because of the vomiting. Okay, now if they do not have any history of vomiting for the last 3 months, okay, then you have a normal bicarbonate. Okay, second thing, they will have a very low body glucose, and that is important because they're not getting any nutrition, not getting any glucose externally, so their body will use all the glucose, right? So they will have a very low glucose. They will have an end organ damage, so they can get a high ALT, AST because of low blood flow. Of course, their cardiac output is very much low. They will have a high amylase. Muscle mass is decreasing, so they will have a low creatinine. Their albumin, because all the protein will be using for the energy, so they will have a hypoproteinemia. They will get a low albumin level. They can get also the edema. They will have a pancytopenia. Okay, because of inhibition of the bone marrow. Any doubt on the anorexia nervosa?
I have one question.
Yes.
Like, what was happening to the GFR because of increased water intake?
So because of an increased water intake, initially you have an increase in the urine excretion, right?
Right.
You can have too much of the diuresis because these patient can use these pills, right?
Right. Right.
In that case, you can also get a low GFR after that. After diuresis, they can have a low GFR also, right?
Okay. Yeah, I got it.
That is the thing. So after you give the patient treatment in the anorexia nervosa, because they're having a very low insulin, sorry, they're having a very malnutrition, right? So as soon as you feed that patient, okay, they can have a high insulin in their body, because whenever they get the glucose in the diet, the insulin will be released. And as soon as the insulin releases, it will cause an influx of the potassium, influx of the magnesium, influx of the phosphate inside the cell. And as a result, patient can have a hypophosphatemia, hypomagnesemia, hypopotassiemia, hypokalemia, right? And that can cause the cardiac complications, that can cause rhabdomyolysis, that can cause the seizures, okay, and that causes the refeeding syndrome, okay. So in the malnourished patient, okay, whenever you give them the carbohydrates, the insulin will be increased. Patient will get the hypokalemia, hypomagnesemia, hypophosphatemia. It's all because of the influx of all these ions. Potassium is needed for the ATP, okay, and you guys already know whenever you got the insulin, you will have an influx of the potassium because of increase in the ATP pumps, right? Sodium, potassium, ATP pump. You will need the magnesium inside the cells for the cell functioning, inside the hepatic cells, inside the muscle cells. So that is the refeeding syndrome. You will get the hypokalemia, hypomagnesemia, and hypophosphatemia. Any doubt?
So
Yes.
in repeat syndrome, it's not that you have an overall lack of these molecules, it's that they have been redistributed to
Yeah,
the inside.
exactly. They're redistribution into the cells. Okay, because of this high insulin, they are all redistributing inside the cells, inside the hepatic cells, inside the muscle cells. Okay.
Okay, and then so was it that before they were fed the carbs, they were in a hyperkalemia, hypermagnesemia,
No, no, no,
hyperphosphatemia?
no. No, they cannot be. Sometimes what happens is they're using too much of the water, as I told you, so they can have a low electrolyte count. And because they are having a diuresis, they're having a vomiting, so that can again cause the low of all these electrolyte level, right? Above that, if you give them the glucose, then the insulin will release and it will cause more hyperkalemia, more hypomagnesemia, and more hypophosphatemia. So they will have a low level always.
Okay, thank you.
It just after giving them the insulin, you're making this condition even much worse. Okay, so make sure whenever you feed the patient, you will always give them these electrolytes because they are lacking it, right?
Okay, thank you.
Now you have the bulimia nervosa. Okay, and in the bulimia nervosa, patient can have a recurrent episodes of binge eating with the compensatory purging behavior, just like my binge eating purging type, anorexia nervosa. But the important thing is the BMI of these patients are often normal, or they can be slightly overweighted. Okay, it is again associated with the parotid and hypertrophy. They can have a high serum amylase. They can have enamel erosion because of the vomiting. Okay, they can have a Mallory-B syndrome, and doesn't even remember what this syndrome is.
Excessive vomiting causes rupture of the esophagus.
Yeah, excessive vomiting can cause a rupture of esophagus. And why is excessive vomiting causing the rupture of esophagus?
Because high pressure like it is that retching thing.
Yeah, because of the high pressure inside your body cavities, inside the stomach, inside the esophagus, it will be destroying your mucosa and some mucosa, right? You're getting a Mallory-B syndrome because of that. Okay, patient can have electrolyte disturbances just like my anorexia nervosa, low potassium, low chlorine. Patient can get a metabolic alkalosis. Okay, they can have the rash on their knuckles, and that is a Russell sign, as it is seen in the anorexia nervosa. So most of the features are overlapping between my anorexia nervosa and the bulimia nervosa. The important thing is look for the BMI. Second important thing that they can get the tachycardia and the hypotension because their heart is not responding to the hypotension. They can get the tachycardia instead of the bradycardia and the anorexia. Okay. Third thing, you won't have the lanugo hairs in the bulimia nervosa because you're having some protein in your body. Okay, so hairs will be normal, but you will get the lanugo hairs in the anorexia nervosa. So these two things only will differentiate between the anorexia nervosa and the bulimia, although everything will be same. Osteoporosis, amenorrhea, arrhythmias, parotid hypertrophy, all things will be seen in both the bulimia and the anorexia. Okay, and the patient can get the patient can have a history of constipation, patient can have a history of abdominal pain, bloating, irregular menses will be there, like you see in the anorexia nervosa, right? And so yeah, that would be about that. And please note, if you encounter a patient with the anorexia nervosa or the bulimia nervosa, you cannot use the bupropion in these patients, okay, because it will decreases the threshold of the seizures, so patient can have the seizures in case of anorexia nervosa and bulimia nervosa if you give them the bupropion. Okay, treatment include the psychotherapy. Okay, of course, a nutrition rehabilitation will be given. Antidepressants like SSRIs are also helpful. Okay, one more drug which can increase the weight of the patient. If anyone remember, I told you in the general pharmacology. Some alpha receptor.
Clonidine.
Not a clonidine. Some alpha 2 agonist. Metrazepine drug, remember? Metazepine.
Yeah.
The metazepine can cause an increase in the body weight, and that's why it is desirable in the underweight patients, right? So you can use this drug in the anorexia nervosa in order to increase the appetite of the patient to get a increase in the body weight. Other drugs that can be used, you can also use, I think, the atypical antipsychotics. Okay, because you guys know that atypical antipsychotics can increases the body weight of the patient, right?
Yeah.
So these drugs can also be used in these patients, right, to get an increase in the body weight. Okay, that is important to remember. So other than the SSRIs, atypical antipsychotics can be used, and metazapine drug can also be used. Okay. So that was about my anorexia nervosa and the bulimia nervosa. Any doubt, please ask.
No, thank you.
Okay. Then third, you have the binge eating disorder, in which patient has no purging behavior. They're just eating and eating too much. So they are basically very much obese. They have a very high BMI, more than 24. You will see in their BMI. Okay. So recurrent episodes of binge eating without the purging behavior. Okay. The patient will have an increased risk of metabolic syndrome. And remember, what does this term mean?
Yeah, hypertension, hypertriglyceridemia, insulin resistance.
Patient will get a very high load of LDL, low load of HDL. They will get a diabetes, increase in the waist circumference, central obesity, okay, increase vascular sclerosis, hypertension, all these negative things you can think about a patient metabolism. That is a binge eating disorder. Treatment includes psychotherapy first time, SSRIs can be given, and lisdexamfetamine can be given, which is an amphetamine again. Okay, because amphetamine can lower your body weight, right?
Yes.
We will see that later. It can cause of weight loss. So these drugs are also very much useful in the binge eating disorder. Then you have the pica, and if anyone remember, we have discussed this pica before in the hematology.
Iron deficiency.
Yeah, the iron deficiency anemia. Okay, so in the pica, you have the cravings of eating the non-food substances like the ice, like the dirt, like the chalk, or even the paint on the walls. Okay, so the patient will have a recurrent episodes of eating a non-food substance. Okay, and it present almost over a 1 month period. It is very much common in the children because they don't understand about all these nutrition values of the food, right? It is also very much common in the pregnancy, and it's also because of iron deficiency anemia, malnutrition, trauma could do that. Okay, and any kind of a developmental disabilities also can do that. Okay, and ice is the most common thing patient will eat in case of pica. That is important to know because it is kind of easily available, right? And the treatment includes psychotherapy, nutrition rehabilitation if they have any malnutrition. Okay, SSRIs can also be given to the patient. And if they're having an iron deficiency anemia, you need to correct the iron deficiency anemia, right? So that was about the pica. And one more thing you will see in the iron deficiency anemia on the nails.
Koilonychia, spoon nails.
Yeah, spooning of the nails. Remember that also. Any doubt on pica?
No, thank you.
Okay. Then you have the gender dysphoria, in which a patient does not accept his gender. Okay, they want to be like other gender. If it is a male, he want to be a female. If it is a female, she want to be a male. Okay, it is of two types: the transgender and the transvestism. Okay, so it is a significant incongruence between one's experienced gender and the gender assigned at birth. It will be lasting for more than 6 months and leading to a distress and the functional decline is important because whenever you have a functional decline, it is always pathological. Okay, individuals may self-identify as another gender. They can pursue surgery or any hormone treatment to change their sex. Okay, and they want to live as a another gender. Okay, it is of first is a transgender. Okay, they are desiring and often making lifestyle changes to live as a different genders. Okay, they will undergo a medical treatment like the surgeries, okay, or the hormone therapies in order to get the gender of others, right? In the transvestism, okay, they have their own gender. Okay, they want to be like other gender. For doing so, they wear the clothes of the opposite sex like a vest. Okay, and that's why the name transvestism. Okay, so this transvestism, if it is causing a significant distress or a functional impairment, you call it a transvestic disorder. Okay, and please note up to the 6 years. Okay, because a child of less than 6 years, they do not understand about all these genders, right? So even if they want to play with girls, if he's a boy and he want to play with girls, or he's using all these toys used by the girls, it is absolutely normal. After 6 years or after 10 years, okay, if they still does not believe in their own assigned gender, if they want to be some other gender, in that case only you will diagnose them with the gender dysphoria. But please note, before 6 years all these things are absolutely normal. Okay, so that was about my gender dysphoria. Any doubt?
No, thank you.
Okay, now you have the sexual dysfunction. Okay, it includes sexual desire disorders, which is a hypoactive sexual desire or a sexual aversion disorder. It may be a sexual arousal disorder, erectile dysfunction. It could be an orgasmic disorder. Patient can have a premature ejaculation or an anorgasmia. Okay, it will be a sexual pain disorder in which patient will have a pain while doing it, right? So it will be a dyspareunia or a vaginismus. Okay, so differential diagnosis you must know. Okay, the one is the psychological. Sexual dysfunction can be due to a psychological dysfunction. Okay, it could be in this case the patient won't have the erection uh, uh, at the time of sex, but they will have a normal erection in the night time. Okay, so you can say that it is a situational dysfunction of the erection, right? The patient will have a normal erection during the night time. Okay, at the time of masturbation it will be absolutely normal. Okay, but they have a impaired erection with the partner, right? It could be due to any kind of a distress in their life, like having and if they're suffering from the relationship. Okay, if they're having any emotional trauma, right? If they're having any anxiety, if they're having any the depression, if they're having any relationship stress, like a fight in the relationship, like going through a divorce process or something like that, then they can have a psychological dysfunction. Second is the endocrine dysfunction. Patient with diabetes, patient with low testosterone, they can have erectile dysfunction. You guys already know that. It could be neurogenic. Okay, it could be due to a spinal cord injury, and we will see that later, how a spinal cord injury can cause this erectile dysfunction. It could be post-operative, right? It could be due to insufficient blood flow, and you call it a Latish syndrome. Remember, we discussed that in the CVS.
Yeah.
Okay, in that case, you will be having a decreased blood flow to the legs and to the genitals, and as a result, you will get a claudication while walking, and you will get the this erectile dysfunction, and there is a Larish syndrome. Okay, then you have due to a substances, it can also cause sexual dysfunction, like the antihypertensive pills. They will cause a vasospasms, and for direction, you need the vasodilation. So antihypertensive pills, diuretic pills, antidepressants, ethanol, all these things can cause the sexual dysfunction also. Okay, so in case of my neurogenic, in case of my endocrine, both the nighttime erection as well as the erection at the time of having sex, it won't happen. In case of my psychological, okay, I will have a normal erection in the night, okay, but it's just a situational dependent. In case of insufficient blood flow, okay, uh, the patient will have a pain or a claudication while doing exercise in the lower legs, and then they will have the erectile dysfunction. Think about the insufficient blood flow, maybe that's atherosclerosis. For substance abused, okay, both the nocturnal, okay, as well as sexual erection will be affected in this case. Okay, so always look for the history of the patient. Okay, if they're having the erection at the time of having sex only, or they're having this erectile dysfunction at all the time. Okay, this will help you differentiating in all these conditions. Okay, any doubt?
I have one question.
Yes.
What was the reason behind antihypertensives causing erectile dysfunction?
Antihypertensives, you can think about them, they have multiple actions, right? It's not just the antidepressants, they have anticholinergic actions, right? For example, they can also block the alpha receptors, right? Alpha 2 receptor inhibitors, they are alpha 1 inhibitors, they are, right?
Okay. And for antihypertensives, right?
Antihypertensives or antidepressants?
Antihypertensives.
Oh, antihypertensives can decrease the blood flow, right? You need the vasodilation in order to get erection, right?
Okay. Yeah.
You're using the antihypertensives like the diuretic pills, for example, then you will have a decreased blood flow. If you're using a beta blockers, they will decrease the beta receptors, and as a result, vasodilation won't occur. If you're using the alpha receptor agonist or inhibitor, something like that. So ultimately, what's going to happen? You will have a decreased blood flow to the penis, right?
Okay. Yeah.
And that causes erectile dysfunction.
Okay. Yeah. Thank you.
Any doubt so far on any of this paragraph on this page?
No,
Any
thank
doubts?
you.
Okay. So that we have already discussed about the anorexia nervosa, all the features, subtypes, additional features, and the lab test you need to run. Then you have the sleep terror disorder. And does anyone remember at what sleep phase you will get the night terrors?
Third,
In the, yeah,
REM3.
REM or NREM?
NREM3.
Yeah, in the NREM N3 sleep, you will get the night terrors. The patient will scream in their sleep. Okay, they will move their legs. They will beat their partner in the sleep. Right? They will do anything in the sleep. They will and they can even sleepwalk in their sleep. Right? But they do not have any memory of that incident. They do not have any memory of their dream, and that's how you know that the dream they have watched, it must be in the NREM phase, because every dream that you watch in the REM phase, your brain will have a memory of that dream, right? So if you remember your dream, that means it will be in the REM phase. If you do not remember the dream, that means it will be in the NREM phase. Okay.
Yeah.
Treatment again include the benzodiazepines, because the benzodiazepines can decrease the N3 sleep time as well as the REM sleep time, right?
Right.
That was about the sleep terror disorder. Then you have the enuresis. For that, I need to open a file again. Just give me a second. Okay, you guys know that the brain causes the inhibition of the micturition reflex, right?
Yes.
And the patient will get the toilet training up to the age of 5 years. Okay, up to the age of 5 years, they will run the toilet training. They will complete their toilet training at the age of 5. Okay, and if their brain is somewhat immature at the age of 5, if right, in that case they will have they won't have the inhibition of the micturition, right?
Right.
And you will call it a enuresis or the incontinence. Okay, so a classical case would be a child who is around 5 years of age, and he has, and please note, they have never achieved any continence so far. Okay, so up to the 5 years, and even after the 5 years, if the child is still bedwetting, okay, you will call it a nocturnal analysis. It is not like that at the age of 4 years they have learned all the toilet training, they've achieved the continence, and then again at the age of 7 or 8 years they started having this bedwetting. You won't call it a nocturnal analysis, but it could be a ego defense sometimes. Remember the
Yeah.
regression, right? So you won't call it a nocturnal enuresis. You will call it a nocturnal uresis. Okay, whenever a patient, a child who is more than or around 5 years of age, he has never achieved any continence, and still, okay, they have this bedwetting episodes more than 5 times a week, and that is a must thing for the diagnosis. A child who is bedwetting for more than 5 days a week, even after 5 years, you will call it a nocturnal enuresis. Patient won't have any daytime incontinence. Okay, episodes mainly occur in the night. Okay, so for that you need to first run the urine test to make sure that the patient is not having any diabetes, because diabetes is also a cause of the uresis, right? Yeah. No.
Repeat what you said.
In the diabetes you will get the excessive urination, right?
Yes.
In the diabetes mellitus, in diabetes insipidus you will get the excessive urination, right? Because of high blood glucose load. Remember?
Yes.
Okay, so you need to exclude first the diabetes by looking for the urine test. You will do the urine test, you will check for the blood glucose levels. Okay, then you can also need to do the UTI test. You will need to look under the microscope, okay, of a urine sample. Okay, once you exclude the diabetes mellitus and the UTI, because in case of UTI you will get the incontinence, right?
Yes.
So please exclude first the UTI and the diabetes mellitus. Only then you will diagnose the nocturnal enuresis. Okay. The pathophysiology is the delayed maturation of the brain, okay, in development of the bladder control. Okay. The patient will have an increased urine and decrease in the bladder capacity. So now comes the treatment. Treatment, first you will counsel the parents that he will eventually achieve the continence. Okay. But even if after 7 or 8 years later, when the child got the age of 7 or 8 years, even if they're still doing the bed wetting, okay, they have never achieved the incontinence even at that age, only then the medical treatment is required. Okay, you will use the alarm. Okay, you will use a desmopressin. And does anyone remember the function of desmopressin?
It acts as ADH.
Attacks.
It acts as ADH.
Yeah, it acts as it is a ADH analog, so it will cause the reabsorption of all the water in the urine, right? You can use the drug imipramine, okay, and which is what category drug?
SNRI.
Imipramine SNRI. No, imipramine, clomipramine, tacipramine, amitriptyline, non-triptyline,
TCA.
tricyclic antidepressants. And why we are using the imipramine?
It acts on ADH receptors, I think. I don't remember.
No.
It works on your ACH, so you do not
Yeah,
want
it
to.
is anticholinergic action because of its anticholinergic action, right? It will block the muscarinic receptors in the bladder, right? And because you know that the muscarinic receptors are required to cause a bladder contraction, right? The detrusor muscles.
Yeah.
So this drug will inhibit the contraction of the detrusor muscles, so you will have the continence. But the side effects again include the coma, convulsions, and the cardiac arrhythmias, right? So that's about the nocturnal enuresis. A child more than 5 years of age never achieved the continence, is still bedwetting more than 5 days a week. Okay, exclude the diabetes mellitus and the UTI first before making sure that it is a nocturnal enuresis. Okay, pathophysiology is the delayed brain development. Okay, in order to get a better control, the treatment is first the counseling that this thing will eventually go away at the age of 7 or 8 years. But even after 7 or 8 years of age, if the patient is still bedwetting, you will give them the medical treatment like the desmopressin, imipramine. Okay.
Yeah.
Any doubt? Please ask.
No, I'm good. Thank you.
Okay. So it is a nighttime urinary incontinence more than. Although it is written more than 2 times a week, but in the U world it is written more than 5 times a week. So I'm not sure if it is more than 2 or more than 5. Maybe the guidelines have been changed. Okay. So what about FA 2021? Is it 2 days or 5 days?
I haven't seen that.
If anyone has FA 2021,
I have
no
it.
one?
I can.
Yeah, please check if it is more than 2 times or more than 5 times a week.
It's gonna take a minute. We can continue and I'll put it in the chat box.
Okay, yeah. So it would be a child who is more than 5 years of age. So first time treatment will be the behavioral modification you will do. Okay, a positive reinforcement. Remember what does this positive reinforcement means?
Yeah, giving a reward for having a positive behavior.
Yeah, to increase my desired behavior, I will give the patient some kind of a reward, right? So for the refractive cases, you will use the bedwetting alarm. Oral desmopressin could be given. Imipramine could also be given. Okay, and you will use the desmopressin over the imipramine because imipramine has a lots of side effects. Then you have the narcolepsy, and I told you to remember one thing about the narcolepsy in the neurology chapter. Remember some protein levels while discussing the
Orexin.
pharmacology. Yeah,
Orexin
orexin
levels.
or the hypocretin. Okay, and because the orexin and the hypocretin, they causes a wakefulness in the body, right? If you have a low level of orexin or the hypocretin, you will have a excessive sleep. In this case, in case of narcolepsy, you will get the excessive daytime sleeping. Okay, and it will always be episodic sleep. Okay, patient will have a recurrent episodes of the sleep. You can think about sleep attacks while you're watching something, while you're doing some kind of a homework, or you're playing, or you're walking, you suddenly get a sleep attack and you just sleep there, right? It happens more than 3 times a week for the last 3 months due to a decrease in the orexin or the hypocretin. Okay, it involves a lateral hypothalamus because of a dysregulated sleep wake cycles you will get. Okay, you will have two type of hallucinations, the hypnagogic and the hypopompic. Hypnagogic hallucinations occur just before going to the sleep. Hypnopompic hallucinations occur before waking up. So patient will hear some kind of a voices just before going to sleep or just after waking up. Okay, patient will have a normal nighttime sleep. Okay, and when they wake up, they generally feel very refreshed after waking up. They have a normal sleep in the night, like 8 hours or 9 hours of the sleep. Okay, their sleep starts with the REM sleep. So they will get the sleep paralysis. Whenever they wake up suddenly, they will find themselves paralyzed because they wake up in the REM sleep. So a history of paralysis is very important during the sleep. As soon as they wake up, history of hallucinations you must check for. Okay, sleep attacks they will get. So so they always tell you that while watching TV, while talking, while doing a presentation, during a class, they will suddenly get a sleep attack. And they will also tell you that after the sleep they always feel very refreshed. Okay, and the very important thing they will have is the cataplexy. Suddenly while moving, whenever they have this laughter. Okay, whenever a a very strong emotional stimulus is given, like a laughter, they will have the paralysis of all muscles. Okay, they suddenly fall on the ground after laughing. So it would be a patient laughing on a joke and they suddenly got fall on the ground, right? So that is a cataplexy. Okay, this condition, it doesn't run in the families. Snoring might be present. Okay, so how would you differentiate between the narcolepsy and one more disorder you will see in the in the respiratory section, that you got due to the
OSA.
OSA, obstructive sleep apnea. So how will you differentiate between the obstructive sleep apnea and the narcolepsy?
OSA patient will be usually obese, while narcolepsy will
While
usually be a
narcolepsy patient can be obese, there is no guideline of the BMI of these patients. I'm getting a
cataplexy will be absent over in OSA.
okay cataplexy. Okay, one thing, and
Would you
hallucination
check?
history is also important. Okay, so
Would you like?
I'm getting a patient. See, I'm getting a patient, and he's telling you that he got a sleep attacks in the morning, in the daytime, while walking. While reading or while writing, while doing anything, right? And they feel very refreshed after sleep. What would diagnose them? Can you diagnose them with the OSA? Their BMI is high, of course. They have no history of cataplexy. They have no history of any hallucinations. They have no history of paralysis in the sleep. They're just telling you that they got the sleep attacks in the morning, and they typically feel after very refreshed after the sleep. The
Yeah,
patient is
well,
obese.
narcolepsy is triggered by like an emotional event versus
But that is a cataplexy which is triggered by the emotional event, not a narcolepsy.
oh, then do you just look for the hypercapnia in OSA?
Hypercapnia can only occur in the nighttime, not in the daytime, in the OSA.
In OSA patients, there will be fatigue.
Okay, fatigue will be in both, I think. Before the
Hypertension
sleep,
will be
of course.
present in OSA patients.
It will only present after a very prolonged time, and generalized, hypertension can be present in any patient. You have a very common thing, hypertension nowadays. See, I'm again very well telling you that the patient feels refreshed after the sleep. And that is a huge hint you will look for. If the patient do not feel refreshed after the sleep, if they tell you that they have this sleep attack, they sleep in the morning, they sleep in the night, and typically when they woke up, they do not feel very much refreshed, because in the night time they have a disturbances with the sleep, right?
Yes.
Because of these disturbances with the sleep in the night time, they do not feel very refreshed. Okay, they have a very disturbance. But in case of narcolepsy, they always feel very refreshed after sleep, and that is a huge hint you must look for. If they tell you that they do not feel refreshed, that means it is the OSA. If they feel refreshed, that means it is the narcolepsy. Okay,
Yeah. Okay.
do remember that. Any doubt on the narcolepsy, please ask.
You have specifically mentioned that narcolepsy doesn't run in families. So how can is this fact important to differentiate it from something else?
I just got an option, for the narcolepsy that the
Okay.
family history about. So,
Okay.
please note that it doesn't run in the family. So no history of any family member is important about that. Okay.
All right. Okay.
If
Thank
they
you.
if they mention that in the option, so you must neglect it.
Okay. Thank you.
Then you have the substance abuse disorders. Okay. And you will have more than two of the following in the past year: a tolerance, withdrawal, intense craving for a substance, using more substance, and like a morphine. If the if a physician if a patient they prescribe you a morphine for a short duration for a pain control, okay, it would be a patient who is using more morphine over a very prolonged time, like for years. Even though the morphine is prescribed them for like a week only, they're using this morphine with the same prescription over like years. So using more drug and longer than what is intended. Okay, persistent the desire but inability to cut down. Okay, they want to stop the drug but they just cannot do that. Okay, it will be a time consuming activity to take the drug. Okay, impaired functioning will be present at the school or the work or at the home. They will have a functional decline. Their work life is very much affected. They have uh, a very poor quality of work. Okay, their behavior will be changing in the school. They have a very social or the interpersonal conflicts. Okay, they stop taking part in some recreational activities. That means they're having a functional decline, of course. Okay, more than one episodes of involving a danger. That means it could be unsafe sex, it could be a driving while taking these drugs. Okay, so a near life death experience it could be. Okay, and continued use despite awareness of the harm. All these things, whenever more than two of the following symptoms is present in a patient, you will think about that they might be having some kind of a substance abuse disorder, which we will discuss later. Don't worry, all the features of different addictive all these agents we'll discuss. Then the stages of change in the overcoming addiction, stage of change in the overcoming addiction. So step one will describe you a scenario of a patient who is thinking about a change or doing a change, or not thinking at all about a change, and they will ask you at what stage of of change the patient is in right now. Okay, so you need to know about all these stages. So the first one is the pre-contemplation. In that phase, the patient is still in the denial that they do not have any problem. Like for a patient who is having a diabetes, okay, they just say you that they're not having any diabetes, they don't want to do anything about it. Okay, they're using all the sugar, they're eating all the junk food and everything like a normal patient. So that means the patient is in the pre-contemplation phase. Then comes the contemplation phase, in which patient is acknowledging the problem. Okay, they tell you that they know that they're having a problem, they're having a diabetes, but they're just not ready to do anything about that. Okay, you ask them to to go and lose weight, but they tell you that it is a problem in their family and everyone in their family has a diabetes. No matter how much they lose weight, they still got a diabetes and all these things. So they are not willing to do anything about it. They don't want to exercise, they don't want to cut down their weight. Okay, although they're acknowledging the problem, yes, that yes, the problem is existing in my family or something else, right? So they're acknowledging the problem but unwilling to do any change. Then comes the preparation phase, when the patient acknowledges a problem and they come to you asking to suggest them any option for a change. So whenever they're thinking about a change, okay, they must be in the preparation phase. They're acknowledging a problem and they're thinking about a change. Then comes the action, when they've decided for the change and now they're doing something about it. they're exercising, they're avoiding their diets, they're taking their therapies, it will be in the action phase. After the action, the patient will maintain it. Okay, and after maintenance, patient sometimes can get a relapse if it is a patient on the alcohol or some kind of a drug therapy. After becoming sober, they started again taking this alcohol, right? So they will again get a relapse, returning to the old behavior and abandoning all the changes. Okay, so these are the 6 phases a patient will always go through whenever they want a change. First is a denial. They're not thinking at all about anything. Then second, they know the problem but they're not thinking about a change. And third, which is the dispreparation phase, they know the problem and they're thinking about a change. In the action phase, they're doing the change. In the maintenance, they're maintaining the change. In the relapse, they're again returning back to the old habits. Any doubt?
I have one doubt.
Yeah.
Since you gave the example of diabetes,
Yeah.
so is this cycle applicable only for substance use disorders or also for such diseases?
For all diseases, it could be applicable.
Okay. All
Like
right.
if you got a cancer, the patient, like, denying the problem that they have no cancer, so they're avoiding all the chemotherapies and everything. In the second phase, they know that they're having a cancer, but it is in the last stage. So just they do not want to do anything about it. Okay. In the third phase, which is a preparation phase, okay, they come to you asking for a chemotherapy, asking for a drug. In the action phase, they're using the chemotherapy, using the drug. In the maintenance phase, they're again maintaining. Relapse sometimes applicable and sometimes not applicable, depending upon in what scenario you're talking about. Okay,
Okay. Okay. Thank you.
so it is available for everything, every disease, every substance abuse. Any doubt on this page, please ask.
No, thank you.
Okay. Then you have psychiatric emergencies, and whenever you encounter any of these symptoms in the patient, you must rush because they are dying, right? The first one is the serotonin syndrome. Okay, for the serotonin syndrome, you must remember all the drugs that can cause it. Okay, any drug which can increase the serotonin level can cause the serotonin syndrome. That means the psychiatric drugs like the SSRIs, SNRIs, TCA, MAO inhibitors. Okay, and all these the paroxetines, okay, buspirone, which are the atypical antidepressant drugs. You will study all of these drugs later. So all of them are increasing the serotonin. They can cause the serotonin syndrome. Then comes other non-psychiatric drugs. Okay, the first one is the tramadol. It can cause it. And remember the tramadol, what category of drug is this?
Opioid.
Yeah, opioids, right? Tramadol is an opioid that can increase the serotonin release. It can cause the serotonin syndrome. One more side effect of this tramadol, I ask you to remember:
Seizures.
seizures. It can decrease the seizure thresholds, right? Third one is the ondansetron. Okay. Fourth one is the triptans. Okay. Lanazolate can cause it. And you must remember this antibacterial drug. Okay. Remember what is the function of this lanazolate is? Mechanism of action.
Vancomycin.
Vancomycin.
Vancomycin resistant drug.
Yeah, VRE. And what is the mechanism of action? No one?
Ribosomal inhibition. 50S.
How? 50S and ribosomal inhibition.
I don't remember that
By
precisely.
inhibiting the assembly of the ribosomes. Right, by binding to a 50S subunit, it will inhibit the assembly of the ribosomes. Just like one drug I told you, which just the same thing. Binding on a 30S subunit. One more drug can do that. Anyone? What? Which one?
You said binding on the 30th, right?
Yeah, binding on 30S, yes. Inhibiting the assembly of initiation complex formation.
Yeah, aminoglycoside.
Aminoglycosides, yes. In the aminoglycosides and the linezolate, they both inhibit the formation of initiation complex. Aminoglycosides acting on a 30S and linezolate acting on a 50S, right?
Yes.
Remember that. So linezolate, which is an antibacterial, can do that. MDMA can do that. Okay, which is a drug of scarcity. We will discuss that later in the addiction part. Dextromethorphan can do that. Meperidine can cause it. Okay, and what does this drug do? Meperidine. What class of drug is it?
Opioid.
Opioids, yes. And the St. John's wort also can cause it. Okay, so remember, you can categorize these drugs first, and then after categorization you can remember. So first are the psychiatric drugs: SSRI, SNRIs, atypical antidepressant, TCA, mouse. Okay, and then the all these opioid drugs like the tramadol and the meperidine. Okay, GI drugs like the ondansetron, triptans. Okay, antibacterial drugs like the linezolid. Addiction drugs like the MDMA. Okay, dextromethorphan can also do that. Remember the function of this dextromethorphan?
Antitussive.
Antitussive, yes. So all these drugs can cause the serotonin syndrome. Categorize these first and it will be easy to remember them. So what is a serotonin drug? What is a serotonin syndrome? You will be having a sympathetic hyperactivity in it. Okay, you will be having the tremors, you will be having a seizures, hyperreflexia will be there, clonus will be there, autonomic instability, that means a sympathetic hyperactivity will be seen, hyperthermia, diaphoresis will be there, diarrhea will be there, and altered mental status. So along with sympathetic hyperactivity, you're also having a diarrhea, and that is the important thing. Okay, so AMS, anxiety, agitation, diarrhea, hyperreflexia, tremor, seizure, clonus, all these are the signs and symptoms of the serotonin syndrome. Treatment is cyproheptadine, okay, which is a first generation antihistamine drug. We will discuss that later, and it is also an inhibitor of the receptor of the serotonin. Okay, then similar to your serotonin syndrome, you also have the neuroleptic malignant syndrome. Okay, in this case also you will get the this hyperactivity of the sympathetic system. You will get all this the hyperthermia will be there, fever will be there, right? But they do not have the diarrhea. Okay, although they can have an altered mental status. Okay, but the main thing they have is the spasms and the rigidity. Okay, they will have a high CK, they will have a muscle rigidity, they will have fever. Because of a muscle damage, they can have a myoglobinuria, they can have an encephalopathy. Okay, they will have a high vitals, just like my serotonin syndrome, high BP, high heart rate in both the conditions. And remember one more condition where you can have a similar symptoms just like the NMS. We have discussed about them in the anesthesia part. Inhaled anesthetics, remember?
Succinylcholine.
Succinylcholine and all these inhaled gases. Remember syndrome name?
Malignant hyperthermia.
No one? Inhaled anesthetics that can cause it, succinylcholine can cause it. We have discussed that. We're forgetting too much. Malignant hyperthermia.
Yeah.
Okay. So in the malignant hyperthermia, you're having a too much of the muscle contraction, right? You will have a rigidity, you will have a high CK, you will have this myoglobinuria, fever will be there, CK enzymes will be there, BP will be there, heart rate will be there, right? Symptoms are all identical to the neuroleptic malignant syndrome. It's just a fancy term whenever you are using the antipsychotics. If the malignant hyperthermia occur due to antipsychotics, you will call it a neuroleptic malignant syndrome. If it happened due to a succinylcholine or inhaled anesthetics, you call it a malignant hyperthermia. Okay.
Yes.
Treatment is again same. You need to give the patient dantrolene, which is a ryanodine receptor blocker. Okay, it is a muscle relaxant. Okay, other drug could be the dopamine agonist, like the bromocriptine can also be used. Okay, so do remember the difference between the serotonin syndrome and this the neuroleptic melanin syndrome or the malignant hyperthermia. Okay, in case of my serotonin syndrome, you will be having a hyperreflexia and this diarrhea along with the sympathetic hyperactivity. In case of my neuroleptic melanin syndrome, you will be having a sympathetic hyperactivity but with the rigidity. Okay, and all this myoglobinuria and high CK enzymes. Okay, then you have the hypertensive crisis. As the name suggests, you will be having a very severe kind of hypertension as well as a sympathetic hyperactivity, high BP, high heart rate. Okay, diaphoresis will be present in the hypertensive crisis. Okay, it happens because of eating a tyramine-rich food. And does anyone remember why this tyramine-rich food can cause a hypertensive crisis? We have discussed that previously in general pharmacology.
Due to MAO inhibition. So there's so there's too many.
Why in the MAO inhibition I'm having this hypertensive crisis after eating the tyramine-rich food?
Because you have too many neurotransmitters. You
I
are not
have?
able. You're not able to break down your
No, no. What does this tyramine doing? What does this tyramine doing in the hypertensive crisis?
Increases the catecholamine.
Yeah, increases the catabocholamine synthesis. Remember the pathway in the biochemistry we have discussed?
Yes.
All this hydroxylase enzyme, the dopamine, the dopa decarboxylase. Remember, and all of this ultimately will form the non-epinephrine and the epinephrine, right? So if you are a patient who is in a mouth therapy and he uses the tyramine-rich foods, then all this tyramine will be converted into the non-epinephrine and the epinephrine eventually, right? And because of this increased release of the non-epinephrine and the epinephrine, uh, sure. So because of this increase in the tyramine-rich foods, okay, you're having an increased release of non-epinephrine and the epinephrine, and that causes the sympathetic activation. So you will have a hypersympathetic activation. So high temperature, high heart rate. Okay, sorry, not a high temperature, but a high heart rate. High BP will be there. Diaphoresis will also be there, and you will get a hypertensive crisis. So it happens with the MAO inhibitor therapy. Treatment will be inhibiting the alpha receptors because ultimately all this norepinephrine and epinephrine will be acting on the alpha receptors, causing the hypertension. Treatment will be to inhibit the alpha receptors by giving the patient phentolamine. And does anyone remember if it is a irreversible inhibitor or a reversible inhibitor?
Reversible.
Reversible inhibitor. Okay, do remember that. Then we have the delirium tremens, and it happens after the alcohol withdrawal. Okay, as the name suggests, patient will be having a delirium and patient will be having a tremors. It happens after 2 to 4 days of stopping the alcohol or the alcohol withdrawal. So if you're a person who is a chronic alcohol user and you suddenly stop the alcohol, not take it for 2 to 4 days, you will have the delirium tremens. Patient will have episodes of delirium. They will have the hallucinations. They will see something. You will have an altered mental status. They become very much aggressive and unable to control. Okay. So all the symptoms of the delirium that we have previously discussed will be present. Along with that, patient also have the tremors, seizures, anxiety, and the sympathetic hyperactivation. The high blood pressure will be there. Okay, high heart rate will be there. Tremors will be there. Seizures will be there. Anxiety will be there. Insomnia will be there. Right? Psychomotor agitation will be there. So sympathetic hyperactivity along with delirium. Think about the delirium tremens. It's all in that name. It happens after 2 to 4 days after stopping the alcohol, mostly seen in the hospital settings because only in the hospitals patient won't get the alcohol, right? So it can only be happen in the hospital settings. Treatment include inhibition of all these sympathetic inhibition of the CNS activities by giving the patient benzodiazepines. Okay, because benzodiazepines can control the acute seizures, acute tremors. Okay, all this insomnia can be treated, right? So benzodiazepines are the drug of choice. Any doubt?
No, thank you.
So do know, they will always give you this timeline of the patient. They will tell you that the patient admitted to the hospital 48 hours ago or 72 hours ago, and now he's starting having these hallucinations and all this altered mental status. Okay, all the symptoms like the tremors. You will think about the tremors. Sorry, you think about it, all the delirium. Okay, but along with the delirium, if they also have a sympathetic hyperactivity, like the sweating, like this tremors, insomnia, nausea, agitation, anxiety, think about the delirium tremors. Now comes the acute dystonia, and dystonia is nothing but a contraction of a group of muscle. Okay, I think I have a separate page. Yeah. Dystonia is a sustained involuntary contraction of a group of muscles. Okay, and it become very much painful whenever you try to move that part of your limb, okay, where the muscle is contracted. It will cause so much pain to the patient. Okay, so it is sustained involuntary contraction which forces a certain part of the body into abnormal, sometimes a painful movement or the postures. It can affect a single muscle or a group of muscle, or sometimes entire body. And does anyone remember any example where the patient got a spasms in the entire body, an infectious cause?
Tetanus.
Tetanus, right? Tetanus. Okay, it is also example of dystonia where you get a contraction of all the muscles in the body, right? Okay, so focal dystonias, they involve a one muscle or a group of muscle. Okay, and you call, for example, you will get a cervical dystonia, right, where you have this abnormal head movement. Okay, abnormal head posture, tilting of a head on a one side. Okay, you call it a spasmodic torticollis. In that case, you're having a contraction in your sternocleidomastoid muscle and the trapezius muscle. So you'll be having a tilting of the head on the opposite side or the ipsilateral side.
Opposite side.
Actually, it is kind of a complex. You're having a tilting of the head on the same side, but the chin will be pointing on the other side.
Yeah, I got it now.
Okay, like if I let me try to draw it. If this is a face of my patient, this is the neck. Okay, you have these sternocleidomastoid muscles, and the function of these muscles is to cause the tilting of the head on the same side. Okay, and it is kind of a rotational movement. Okay, so you will have a chin movement on the other side and a tilting of the head on the same side. Okay,
Is
Yes.
this
so it is
on
kind
the
of a
left?
rotational along with a tilting movement like that. This kind of a movement you will see on the head of the patient. Okay, so that is about the cervical torticollis, a cervical dystonia, sorry, or the spasmodic torticollis. You can also get the blepharospasm. Okay, it happens because of a focal dystonia in the eyelid, and that causes a forceful closure of the eyelid. You cannot open your eyes. Does anyone remember what nerve causes the opening of the eyes?
Oculomotor and the
Oculomotor.
sympathetic chain.
And the closing of the eyes is done by the facial nerve,
Facial.
right? Okay, in case of blepharospasm, you're having a contractions in the muscle responsible for the opening of the eye. Oh, sorry, responsible for the closing of the eye. You will get a forceful closure. Okay, it will start with in the very initial patient will have a blinking. Okay, and later they have a complete closure of the eyelid. So this is the blepharospasm. Other type of spasms can also occur depending upon the muscle groups. Okay, so that about the acute dystonia. Okay, this acute dystonia generally happens because of a extrapyramidal side effect of the antipsychotic therapy, especially the typical antipsychotics. They can cause it. Okay, patient can also have a oculogyric crisis. In this case, you will have a upward and outward movement of your eyes. Okay, because of contraction of the extraocular muscles, and this is the oculogyric crisis. Okay, and please note the timeline of all these symptoms of the all the side effects of your atypical antipsychotics is important. Shortly after taking a drug, after hours or week later, just within a week, you will get an acute dystonia. Then later on you will get this chorea symptoms or the akathisia, right? And if you get too much of the drug, you can even get the neuroleptic malignant syndrome. So we will discuss all these timeline later when we discuss the atypical antipsychotics. Just know for now that shortly after taking a drug, you can have a acute dystonia. Treatment include giving the patient benztropine, which is an inhibitor of my acetylcholine, or you can also give the patient diphenhydramine, which will inhibit the histamine, inhibit the alpha receptors as well as my acetylcholine receptors. Okay, any doubt?
No, thank you.
One more
So
thing, if you, yeah, just give me a second. If you have a laryngospasm, then you must know that, all the air passes through the larynx, right? First, okay,
Could you
all
please
the
repeat?
all the air which is going into your lung, it must passes through the larynx first, right? The voice box.
Yeah.
If you have a laryngospasm, it will block the passage of your air into the lungs, and that means in that case you will require the intubation also. This condition becomes so much severe, it can lead to a death of the patient because of this gasping of the air, right? So it could be mild, it could be so much severe, can lead to the death of the patient also. Now ask any doubt.
So when you were talking about the blasphemopathy,
Blepharospasm.
sorry, blepharospasm,
Blepharospasm.
blepharospasm, that is that due to your facial nerve closing too much, like it's doing excessive closing?
It has nothing to do with the nerves. It has to do with the muscles only. The nerves, the muscles which are supplied by those nerves. Okay.
Okay.
It has
Okay.
nothing to do with these nerves at all. It just, after it, they're, directly causing the contraction of the muscles. Okay.
Yeah. Okay. Thank you.
Okay. Thank you. So now comes the lithium toxicity. Whenever you have a high dose of lithium, which is a drug you use for the bipolar disorder, okay, you can have a toxicity. The toxicity can be due to an increased dose if you have a too much of the lithium, or it could be due to a decreased elimination of the drug. The main path for the elimination of the drug is the kidney. So if you have a patient who is having a chronic kidney injury, a chronic kidney disease on the dialysis, maybe it could be a patient on the ACE therapy, that means diuresis, so a decreased blood flow. It could be a patient on the thiazide diuretics, or a patient on the NSAIDs, because NSAIDs compete for the excretion. Okay, so all these agents can decrease the clearance of the lithium and can cause a lithium toxicity. Patient will have a normal GI symptoms like the nausea, vomiting. Okay, they will have some neurological symptoms like the hyperreflexia, seizures, ataxia, and they can also have a nephrogenic diabetes insipidus, because the lithium can directly inhibit the receptors for the ADH. So a patient having a GI symptoms like the nausea, vomiting, some neurological symptoms like the hyperreflexia, seizures, ataxia, think about the lithium toxicity. They might be having a history of bipolar disorder, or they might be or sometimes they can give you a case of lithium itself. They will tell the patient is on a lithium therapy. They will ask you, why is the toxicity occurring in the patient? So look for the comorbidity of the patient. If they are a patient having a hypertension, or if they're a patient having a chronic kidney disease, or a patient having some kind of inflammation, so choose a drug accordingly. Okay. Treatment include giving the patient this hydration. Okay, you need to hydrate the patient first. Okay, you need to give the patient a sodium chloride. Okay, and consider the hemodialysis of the patient. You need to remove all this lithium in their blood. Okay, then you have the tricyclic antidepressants, all these prime drugs, the imipramine, clobipramine, amitriptyline, non-triptylines, right? The overdose can cause 3C, the convulsions, which means all this epilepsy thing, all the seizures. You will get the coma, and you will get the cardiotoxicity. In this case, you will get a prolonged QT. Okay, treatment include giving the patient sodium bicarbonate, okay, and which will prevent the arrhythmias. And you can also give the patient activated charcoal, okay, to remove all this drug from the GI tract. Okay, it will inhibit the absorption of the drug in the GI tract. So this activated charcoal can also work if the patient present very acutely. Only 1 to 2 hours after the ingestion, you can give the patient activated charcoal. But if you think that the drug is absorbed in the blood now, you have to give the patient bicarbonate to eliminate the drug. You need to monitor the ECG of the patient and giving all these anti-arrhythmic drugs accordingly also. Okay, so a patient with a respiratory depression, hyperreflexia, seizures, QT prolongation, think about the TCA therapy. Okay, and does anyone remember all the drug names that can cause acute prolongation?
A, B, C, D, E drugs.
A, B, C, D, E. For A, you have the antiarrhythmic drugs, the class 1A and the class 3. Okay, with the B, you have
Antibiotics, fluoroquinolone,
yeah, fluoroquinols and
macrolides.
macrolides. For the C, you have antipsychotics. Okay, with the D, you have antidepressants like the tricyclic antidepressants. With the E, you have antiemetics. And what antiemetic can cause it?
Ondansetron.
Ondansetron, right? And one more drug, the opioids like the methadone can also cause the QT prolongation. Okay, do remember that also. So any doubt on this page?
No, thank you.
So just know almost in all of these diseases, in all of these emergencies, you're actually having a sympathetic hyperactivity, right? So just look for the keywords for every disease. Like in case of serotonin syndrome, we will be having a seizures with the diarrhea. In case of hypertensive crisis, you're just going to have a hypertension and sympathetic hyperactivity, of course. In the neuroleptic malignant syndrome, you will be having a rigidity in the muscles. The patient cannot move their hand. Okay, they have pain while moving a hand and this myoglobinuria. In the delirium tremens, you will be having a sympathetic hyperactivity with delirium and the tremors. In the acute dystonia, focal muscle contraction. In the lithium, you will be having a hyperreflexia. Seizures can happen. Okay, and you will have a diabetes insipidus and the GI symptoms like the nausea, vomiting. In the TCA, coma, convulsions, and the cardiotoxicity. So look for the keywords or the buzzwords, okay, to remember all these things. They must give you these specific feature for every of the of this emergency in order to diagnose it, right? Remember the treatment. They will ask you what treatment you must given to the patient, or they can ask you the cause of it. Okay, what drug is causing this condition? They will ask you. So now the psychoactive drugs, intoxications, and their withdrawals. First, we discuss, all these parasympathetic, or you can say, CNS depressant drugs, and then we discuss all the CNS stimulant drugs that can also cause the, the sympathetic hyperactivity. So we will discuss after a short break. Okay.
Okay.
Okay. It was 2 episodes. Okay, for 1 week. Okay, and more than 3 months of history is required. Okay. So a patient who is 5 or more than 5 years of age and is still bedwetting for more than 2 times a week, okay, for greater than 3 months, it will be the nocturnal enuresis. Okay.
Yes.
And now comes all these addictive agents or these drugs for the intoxications and the withdrawal. Okay, first we discuss the depressant drugs, and all of these drugs causes the CNS depression. Okay, all of these drugs can cause the drowsiness. Okay, and all this can cause the the sleeping, excessive sleeping will be there. All of these drugs can cause the CNS depression, the CVS depression, and the respiratory depression. Okay, so these are the non-specific symptoms that you will see with any of these drugs. For the withdrawal, whenever you withdraw the agent, okay, the hormone, all these neurotransmitters level, all these receptors, these drugs are inhibiting. Okay, the level of all these all these neurotransmitters will be rising already, right? So as soon as you stop these drugs, all these increased neurotransmitters will stimulate the receptors, and they will cause activation of all the opposite effects. Like if these are a drug which are inhibiting your respiratory system, you will have the tachycardia and the trachypnea. Okay, you will have if these drugs are causing the depression and the sedation, then after the withdrawal you will be having the anxiety and tremors. Okay, if these drugs are are making you sleepy, okay, then after the withdrawal of these agents you will get the insomnia. So just the opposite effects. The first one is the alcohol. After drinking alcohol, you will become very ataxic. Okay, will have some kind of you will become very emotionally liable. Okay, slurring of the speech will be there. Okay, blackouts can also happen where you do not remember anything that happens with you, an incident. Okay, the withdrawal of the alcohol is very important, and you need to look for the timeline of the patient. Okay, let's suppose at this time, at the point zero, the patient stopped drinking, and these are the hours. Okay, as soon as the patient stopped drinking, and we're talking about a patient on a chronic alcoholism, okay, that required almost who is drinking almost a bottle of alcohol every day. Okay, so these kind of a patient, as soon as they stop drinking, within 3 hours they started having all these hyperactivity symptoms, autonomic hyperactivity symptoms. Like patient will get the agitation, patient will get that all these tremors, he will have that aphoriasis, GI upset, high heart rate could be there, okay, high BP could be there. Okay, then soon within 6 hours, patient can start having the withdrawal seizures that can happen up to the 48 hours. Okay, after 12 hours, patient can start having the hallucinations. Okay, and after 48 hours, patient can have a delirium tremens. Okay, so look for the timeline of the patient. Within 3 hours, sympathetic hyperactivity. After 6 hours, withdrawal seizures. After 12 hours, hallucinations. After 48 hours, delirium tremens. And we have discussed already what this delirium tremens is. So they will always give you a timeline of the patient whenever they want to give you a case of alcohol withdrawal. And after giving the timeline, they will ask you what other symptoms could be expected in this patient. Okay. Any doubt?
Okay.
For the treatment, you need to again, for the alcohol withdrawal treatment, you need to give the patient again a depressive agent, which is the benzodiazepines. Then comes the barbiturates. Just like any other depressant drug, they will decreases the respiratory rate, the respiratory rhythm. They will decrease the, they will inhibit your CVS system. Okay, they will cause, the CNS depression. They will make you very drowsy, very sedative agents they are. They have very less safety margin, and they can even lead to the death of the patient because of the respiratory failure. So whenever you encounter a patient having a very high drowsiness, okay, altered mental status, having a CNS depression, CVS depression, or the respiratory failure, think about the barbiturates. Treatment is only supportive. You could give, okay, for the decrease in the BP, you could give the patient any sympathetic agent that can increase the BP of the patient. You can give the patient oxygen therapy for the respiratory depression and all these things. Okay, so assisted this respiration will be given, high BP agents could be given. Okay, so all the tips on all the treatment are only the symptomatic management. Okay, with the withdrawal, you can have a certain seizures, you can have a delirium, life-threatening cardiovascular collapse can also occur. That's an important. Okay, then comes the benzodiazepines, and these drugs are rarely fatal. They have a very high safety margin. Okay, with the benzodiazepines, as I told you already, you will have just the CNS depression and a very little CVS depression. Okay, it would be a patient who is having a very drowsiness and altered mental status. Had the patient will be very much sleepy. Okay, they have a very mild decrease in the heart rate, a very mild bradycardia. Although they are and some mild this respiratory depression can also occur. Okay, so think about the benzodiazepines whenever you have a patient who is very drowsy, having a mild respiratory depression and almost normal vitals. Okay, it is the benzodiazepines. And as soon as you withdraw these agents, patient can have a recurrent seizures, precipitations of seizure can happen, anxiety, tremors, insomnia. Okay, sympathetic hyperactivity can happen after the withdrawal of these agents because they're causing the depression in the CNS, CVS, right?
Yeah.
For the treatment, you can give the patient flumazenil, which is a competitive inhibitor or the of the benzodiazepine receptors. Okay, if you give this agent, you can precipitate the seizures again. Okay, so a patient who is having a very mild respiratory depression and a very mild serious depression, that means a heart rate could be little less than 72. Okay, and the respiratory rate could be around 16 or 14. Okay, and the patient will be very much drowsy, very much altered mental status, confused. Think about the benzodiazepines. Versus in case of opioids, along with the CNS depression, that means the drowsiness, sleepiness, and all these things, patient will have a very marked respiratory depression and a very marked serious depression. He will have a hypotension, he will have a bradycardia, he will have a improper respiration. Okay, patient will have a drowsiness, patient will have all this sleepiness. Okay, pupillary constriction will be seen, but a pupillary dilation could be seen with Opioids can cause the pupillary constriction, but one opioid can cause the pupillar dilation. Anyone?
Methadone.
No, not the methadone. Meperidine. Okay.
Okay.
So meperidine can cause a pupillary dilation. Rest all other opioids can cause a pupillary constriction. Okay. Patient can have a seizures also sometimes, right? And patient will also have a constipation. Remember, all the opioids can cause the constipation.
Yeah.
Okay, so a patient with the constipation having a very low respiratory rate, it could be around 5 or 10 only, having a very low heart rate, around 50 or 40, having a very low BP, okay, around 100, which is, instead of 120, BP will be 100 of the patient, right? So I look for the opioids versus if the patient having a just CNS depression and a very mild respiratory and a mild cardiovascular depression, think about the benzodiazepines. With the withdrawal of the opioids, patient can have a withdrawal symptoms, and a very specific withdrawal symptoms are there for the opioids. These are the dilated pupils because you're having a constriction with the use. So dilation with the withdrawal. Specific ones include a lacrimation, yawning, okay, diarrhea, and stomach cramps. So if you encounter a patient having a lacrimation, yawning, diarrhea, stomach cramps, dilated pupils, sweating, think about the withdrawal of the opioids. Okay.
Yeah.
Then you have the inhalants, and the only thing that you must remember for the inhalants that it is used by the teenage patients, teenage person. Okay, it could be a teenage one who is in the school, or who is still not in the school but in the age which is before 18 years. Okay, so it is basically misused by the adolescents. Okay, patient will present you with the slurred speech, disturbed gait, okay, altered mental status could be there, change in behavior could be there, drowsiness could be there. Okay, so the important thing to remember is that all the patients, okay, if you want to choose the answer as the inhalants, it must be a patient of the adolescent age. Okay, because it is most commonly misused by the adolescents. Okay.
Yes.
Okay, so that was about all the depressant drugs. They will cause a CNS depression, they will cause a respiratory depression, and they will cause the CVS depression. Okay, any doubt, please ask.
So for all these like intoxication and withdrawal, we should focus more on those specific symptoms.
Yeah, because the common ones are always the drowsiness and all these things, right? Specific ones will make you exclude all the other options. Like in case of opioids, the specific ones are the yawning and it is lacrimation and diarrhea. In case of benzodiazepines, nothing is specific, it is always a non-specific one. Barbiturate case, it could be a death of the patient ultimately. Okay, or the patient might be on a supportive therapy. For case of alcohol, think about the delirium tremens and all these tremors, insomnia, sympathetic activity mainly. Okay, if you have a very mild CVS with depression, a mild respiratory depression, and a mild CNS depression, think about the benzodiazepines. If you have a very severe CNS, CVS, and respiratory depression, think about the opioids. Okay, if they're giving you a timeline of the patient, then most probable chances are that they're giving you a case of alcohol. Okay, so look for these kind of hints.
Okay. Yeah. Thank you.
If the patient is of age of adolescent, right, less than 18 years, like around 12 to 15, think about the inhalants. Now we have the stimulants, and they will all cause a sympathetic hyperactivity. They will cause a mood elevation. They will decrease the appetite. Patient will have a psychomotor agitation, tachycardia, anxiety. Arrhythmias can occur, insomnia can occur, high BP can occur, pupillar dilation can occur, right? Chest pain can occur because of vasospasm due to these agents. Okay, with the withdrawal, you will get a depression effects. Okay, see, intoxication effects of all these agents are the withdrawal effects of all these agents. Is that okay?
Right.
Okay, all the side effects or the symptoms you will get after intoxicating these agents are the withdrawal effects of all these agents, stimulants. Because after you use the stimulant, as soon as you stop using them, you will get a depression, the CNS depression, the respiratory depression, and the cardiovascular depression. They will have an increased appetite, lethargy, depression, sleep disturbances, nightmares, and all these things are kind of non-specific for all these agents. The one is the amphetamines. Again, whenever you use the amphetamines, you will have a high epinephrine levels. And as a result, patient will get all the sympathetic hyperactivity, high BP, hypertension, high heart rate will be there, right? Anxiety, tremors, okay, paranoia could be there, pupillary dilation will be there, euphoria will be there, right? The specific one to look for is the fractured teeth. They will have a tooth decay, using the amphetamines will weaken your teeth. Okay, so look for the, any kind of a symptom if they're given you are related to the teeth. Think about the amphetamine, either the tooth decay or the tooth fracture. Okay, and because you use these drugs, IV or skin excoriations could also be there. Okay, if you use them very severely, very in intoxication, the cardiac arrest can also happen. Seizures can also happen. Okay, for the treatments, you need to inhibit your CNS, CVS, and respiratory part. So you will give the patient benzodiazepines. Okay, similar thing goes for the caffeine. You will have a palpitations, agitations, tremors, insomnia. Okay, symptoms are always mild with the caffeine. It would be a patient drinking too much of the energy drinks or too much of the coffee, so they can have a toxicity with the caffeine. Okay, any doubt?
No, thank you.
So for the withdrawals of the benzodiazepines, we'll be having a diarrhea, lacrimation, yawning. For the for the withdrawal of the benzodiazepines, so we'll be having a anxiety, seizures, tremors, typhoriasis, pupillary dilation, palpitations, and all these things. Then you have the cocaine, and you know that cocaine will increases the non-epinephrine and epinephrine in the synaptic cleft. It can cause the vasospasms. Okay, and the important thing you will get is the hallucination. Although you can get hallucinations when any of this agent, okay, but for the specific one, look for the cocaine. Okay, you will get tactile hallucinations. And does anyone remember what this tactile hallucinations mean?
Yes, the person feel ants or other
Yeah,
insects are crawling.
like something is crawling on their chest, on their abdomen. They will tell you, right? So they will have a pupillary dilation because of sympathetic hyperactivity again. The patient will be having an angina pain because of the vasospasm. Cocaine can cause the vasospasm of the coronary vessels. It can cause the angina, and it can also cause the myocardial infarction, especially if the patient is if the patient is having a history of vasospastic angina. In that case, cocaine can cause a myocardial infarction. A sudden cardiac death can occur because of the arrhythmias. Okay, and because the most common route of intake of the cocaine is by the nasal route. Okay, so the nasal vasoconstriction can occur, and because of the constriction, patient can get the perforation of the nasal septum. Ischemic necrosis, you can say, will happen. Treatment again include giving the patient depression drugs like the benzodiazepines. Okay, a mix of alpha beta blocker must be given. You cannot give the patient beta blockers before giving the alpha blockers, because in that case the cocaine will stimulate only the alpha receptors. You will get a profound vasoconstriction and a profound hypertension. So always give a mixed alpha beta blocker. Pure beta blocker cannot be given. Okay,
Yes.
so the important or the specific things you will look for are the perforated nasal septum. This is the most important thing you will see. Okay, hallucinations can happen with any of the agents, with the cocaine, with the nicotine, with all these hallucinogens. They can cause these hallucinations. So it is not very much specific, or the most of the time you will see the hallucinations with the cocaine. But still, don't choose your answer as cocaine. If you just see the hallucinations, look for the other hints also, like all the sympathetic hyperactivity. Especially the angina pain is very important, specific for my cocaine, and the perforated nasal septum is very much specific for my cocaine. Okay, so these two will help you differentiating the cocaine with other agents. All right.
Yeah.
Then comes the nicotine, and it can cause a restlessness. Okay, the withdrawal of nicotine is important, although I have never encountered any question on the nicotine. But the withdrawal can give you irritability, anxiety, restlessness, again, decrease in the concentration, increase in the weight. Okay, treatment include giving the patient some agonist on the nicotine receptors, okay, like the nicotine patch, gums, okay. You can also give them the nicotine blockers, okay, or some partial agonist can be given, okay. So bupropion, varenicline, these are the agents you will give for the nicotine withdrawal, okay. Then comes, so any doubt on these stimulants?
No, thank you.
They all have pretty much same symptoms. So one or two words only will help you differentiating with each of them, right? Of course, you can easily get a difference between all these depressants and the stimulants, right? You just need to differentiate between the depressants and between the stimulants itself. Then comes the hallucinations, and all of them can cause the hallucinations. Okay, the first one is the LAD, lysergic acid diethylamide. Okay, you will get the visual or the auditory hallucinations. Okay, it will be remembered as a bad trip. Okay, patient will get the paranoid delusions. He will become very much suspicious of other. He will get the anxiety. Depersonalization can occur. Patient will feel like that they're outside their body. They're seeing their body with their own eyes. Okay, they will feel like everything is in a fog or like they're in a dream or something like that. They will cause. It will also cause the flashbacks. Okay, very important. So yeah, patient will get the visual hallucinations. Okay, sympathetic hyperactivity can also occur with the LAD. You will get a the diphoriasis. Patient can also get a panic attack. Tachycardia, hypertension can occur. Okay, so just remember the paranoid delusions are very much important. You will see it will be remembered as a bad trip. Flashbacks are also very much important, differentiated with other conditions. Okay, then you have the marijuana or the cannabinoids. Okay, so marijuana, the important thing you look for is the is the redness in the eye. Okay, and that is the most specific thing with the marijuana. Okay, the redness in the eye, you will get the conjunctival injection with that. Okay, other specific things are the slowing of the reflexes, perception of a slow time. Okay, they will have very impaired time perception. They will have an increased appetite. Whenever you smoke marijuana, you will always get too much hunger, so you will have an increased appetite and you will get a dry mouth after it. Okay, so important thing you will look for is the conjunctival injection or the redness of the eyes, increased appetite, delayed perception of the time, and delayed reflexes. These four symptoms will help you differentiate marijuana with other hallucinogens. Okay,
Yeah.
and generally patient who smoke marijuana, they also sometimes get the social isolation. They withdraw themselves with others, and just they lock themselves in a room and smoke marijuana all day. Then comes the MDMA, okay, and it is again a hallucinogenic stimulant. Okay, it will cause all these sympathetic hyperactivity symptoms as well as the hallucinogens, because it is. The important thing you look for is the increased thrust and the bruxism. You will get the euphoria, increased energy, disinhibition, hyperactivity, just like with any other disease, any other drug. You will get the hypertension, tachycardia, hyperthermia. So all these things won't help you differentiating with others, right? The bruxism and the thrust will help you do that. And please note, most of the times, whenever you encounter a patient having the MDMA toxicity, okay, they will always get it after a club party. Okay, so all night party, after an all night party, they are having this bruxism and thrust and hyperactivity. Okay, so remember that it is also known as the club drug. It is most commonly sold in the clubs. So a history of club party is very important. Okay, hyponatremia is also very important, because after using the MDMA, patient will get the thrust, and when they get the thrust, they will drink too much of the water, that will cause the hyponatremia. Patient can also get the serotonin syndrome that we have discussed previously. So they can have the tremors, they can have a diarrhea, they can have hyperreflexia after that. Okay, so look for the history of serotonin syndrome after a club party. Think about the MDMA. Okay. Is that okay?
Yeah, thank you.
And then you have the phenylcyclidine, which is again a NDMA antagonist. And remember any other drug which is NDMA antagonist we have studied? Any anesthetic agent, IV anesthetic?
Ketamine.
Ketamine, yes. Ketamine is also an NDMA receptor blocker, okay? So phencyclidine, remember 1 to 2 things about it. Violence is very important. Patient after using this drug becomes so much violent, they start beating all these security guards, their partner or even the policeman's, okay? So violence is very important, okay? Patient will become very hallucinogenic, okay? They will have this visual hallucinations. They are talking to someone or they are responding to the, yeah, bruxism is a teeth grinding. Okay, they will have the hallucinations. They respond, and sometimes step one will describe you a case of hallucination. They will tell you that the patient is responding to some kind of a internal stimuli. Okay, so this internal stimuli means they're talking about the hallucinations. Patient will become very much aggressive. Okay, they start fighting, start violencing. Okay, and the very important thing is the nystagmus. Okay, and patient will get a vertical nystagmus after using this drug. So history of violence, history of hallucination, and history of vertical nystagmus. This is a classical triad of the phenylcyclidine. And please note, patient do not remember anything about these episodes. Next day, they just woke up and they forget everything. They don't remember what happened to them last night, okay? They have an anterograde amnesia after using this drug. So a classical triad of violence, nystagmus, and hallucinations. And after that, no memory of all these events. Think about the phenylcyclidine, okay?
Yeah.
Then you have the alcohol use disorders, okay? And I told you, you will get the complications like the vitamin B1 deficiency. Alcoholic cirrhosis can happen, hepatitis can happen, pancreatitis can happen because of a blockage of the pancreatic duct at the ampulla of Vater. Peripheral neuropathy can occur because of vitamin B6 deficiency sometimes. Testicular atrophy can happen because of a damage in the pituitary, and this memory bodies, damage in the brain, I must say, right? And you will, in the previously I've discussed all these symptoms you will get in the intoxication and the symptoms you will get after the withdrawal, right? Now comes how will you manage an alcoholic disorder patient. For the acute management, whenever you encounter a patient having a withdrawal from the alcohol, you will always give them the benzodiazepines, okay? To reduce the cravings, you will use the naltrexone. Okay, a camprosate can also be given. Disulfiram you do not use nowadays. Okay, but it is used to discourage the drinking because the disulfiram is an inhibitor of what enzyme?
Acetaldehyde dehydrogenase.
Acetaldehyde dehydrogenase. So you will have a high level of acetaldehyde in your body that will cause all this abdominal pain, nausea, vomiting. So it will discourage the patient, from drinking. But you do not use this agent mainly. You will use mainly the naltrexone and the camprosate. Okay. So support groups are also very much helpful to make you sober. Okay. Then you have the Wernicke-Korsakoff syndrome. We have discussed that already in the biochemistry, right? You will have a triad of all these confabulations, ophthalmoplegia, ataxia, and memory loss, right? And memory loss is always irreversible. Treatment include giving the patient vitamin B1 before giving the patient dextrose. Because if you give the patient dextrose, then all of the stores, remaining store of the vitamin B1 will be depleted and patient will get an acute precipitation of all these symptoms, right?
Yeah.
So that was a Wernicke-Korsakoff syndrome. Any doubt on this page?
I have one question.
Yes.
Just like MDMA, is phencyclidine also like a drug which is used in clubs and bars?
Yeah. It is also a drug which is used in the parties. Mostly patient will have a history of a night party before that. Okay.
Okay. Yeah. Thank you.
But they specifically mention you a club thing or the trust and hyponatremia and specifically the serotonin syndrome, they might give you a case, So a
Right.
serotonin syndrome after a party, you will always think about the MDMA, of course.
Okay. Thank you.
Okay. Now comes the pharmacology. All these behavior therapies, although they have never asked me step one, okay, I've never encountered any question over that. So it is kind of a step two stuff mostly, okay. So I think we can skip that, but for just know that the dialectical behavioral therapy can be used for the borderline personality disorder. This is an important one. Okay, Cognitive behavioral therapy is mostly used in case of anxiety, in case of depression, in case of any other conditions, in case of PTSD, right? CBT is very much useful for that. Okay, only if the CBT is not given in the option, then only you will use the drug therapies as the option, right? If the CBT is given in the option, always choose a CBT first as a treatment. Okay.
Okay, yeah.
Supportive therapy is also very much important to make the patient sober, or to help patient cope up with their all these addictions and all these things. Okay, this is an important part. The preferred medical this treatment for a selected psychiatric conditions. For the ADHD, you can use the stimulants like all these amphetamines, clonidine, guanfacine can also be used, alpha 2 receptor agonist. For the alcohol withdrawal, you will use the benzodiazepines. Okay, for the acute therapy, you will use all these atom drugs. Remember ATOM.
Yeah.
Okay, for the maintenance, for the long term time, you can use the chloride epoxide, which is a very long term agent. Diazepam can be used. It has, I think, a half life of 24 or 48 hours. I don't remember exactly. Lorazepam has a half life of, I think, 12 hours. So all these agents can be used. Okay, bipolar disorder, lithium is a drug of choice, of course. Okay, if it is maniac dominant, what drug would you use among these?
Valproate.
Not the valproate. Lithium for the maniac dominant, right?
Okay. Okay.
Lamotrigine for the depressant dominance. Valproic acid and carbamazepine having a fluctuations. Those patients are having a fluctuations, right?
Yeah.
So remember these agents. Atypical antipsychotics are also very much helpful. Then you have the bulimia nervosa, SSRIs, anorexia nervosa, SSRIs. Please note, you cannot give the patient bupropion. It will cause a seizures in that case. Depressions, SSRIs. Anxiety, SSRIs. OCD, SSRIs. Panic disorder, SSRIs. Remember, whenever you are forgetting the drug name specifically, okay, and you want to make a guess, always tick the SSRIs as the option. As you can see, in most of these conditions, you are using SSRIs as the treatment, right?
Right.
So if you're forgetting the option or the correct answer and want to make a guess, always choose the SSRIs. Most of the time, it was going to be a correct answer. Okay, so PTSD, SSRIs, schizophrenia, of course, you cannot use the SSRIs, you must use the antipsychotics. Okay, social anxiety disorder, SSRIs. For the performance anxiety, in this case, patient, refrain from performing in a specific situations like like standing on a stage or something like that. You will use the beta blockers for that. In that case, patient got very high heart rate and diaphoresis and this high BP. To control that conditions, patient uses you will have to give the patient beta blockers for the performance only. In normal in normal conditions, give the patient SSRIs. Tourette syndrome, antipsychotics would be given, and tetrabenazine, which is a VMAT transporter inhibitor. Remember,
Yeah.
these things are given. Then comes the stimulant agents. Okay, all these amphetamine drugs, they all have this amphetamine in their name. Okay, and methylphenidate is also one. Okay, they increases the release of all the non-epinephrine and the epinephrine and decreases the uptake of epinephrine and non-epinephrine. Clinical use will be ADHD, narcolepsy, and binge eating disorder. Okay, because in binge eating disorder, you want to decrease the weight of the patient, and these drugs can cause a weight loss. Narcolepsy and ADHD can also be used. Adverse effects, of course, sympathetic hyperactivity, like we have discussed before. You will get the agitation, nervousness, anxiety, insomnia, tachycardia, hypertension, weight loss. Okay. So if it is a patient, if it is child of the ADHD, and you have given them the this these drugs like the methylphenidate, you always has to monitor the weight, height, and heart rate and BP of the patient. Okay, you have to keep following the patient monthly. Okay, you have to set the monthly appointments of the patient, and every time you need to measure the weight, height, and BP, heart rate of the patient, because they can cause the weight loss. They can cause all this malnutrition thing. If the patient does not increases their diet, it can cause a high heart rate, high BP. Okay, nowadays, instead of using all these stimulants, you're also using the modafinil as the agent because it is a non-amphetaminic stimulant. Okay, this drug cannot be misused and it is also a well-tolerated drug. So instead of all these stimulants, modafinil is also a treatment you can give to the patient of ADHD especially. Okay.
Yes. And is modafinil also used in narcolepsy?
I'm not sure about the narcolepsy, but it is surely used in the ADHD. I've studied
Okay.
that. Okay.
Okay. Thank you.
Okay, then you have the typical antipsychotics. They are the dopamine receptor blockers. Okay, they decreases the dopamine levels in the in the mesolimbic system and the mesocortical system, right? In the pathways. And you guys know that the mesocortical pathway is responsible
Positive symptoms.
for the negative symptoms, and the mesolimbic pathway is responsible for the positive symptoms. Yes.
Okay. Yeah.
Okay. So all these typical antipsychotics, you're using them for the schizophrenia. Okay, they block the dopamine receptors. They can be used for, of course, schizophrenia, psychosis, bipolar disorders, deliriums. Okay, and delirium, the vitamin H, remember?
Haloperidol.
Haloperidol, yes. Okay, Tourette syndrome you can use. Okay, Huntington disease, because with the Huntington disease you can also get the psychosis sometimes. So these drugs are useful. OCDs also you can use, but the SSRIs again are a treatment of choice, right? So these are all the uses of the all these typical antipsychotics. Potency, you have two types. Okay, one are the high potency and second are the low potency. Okay, haloperidol and the flufenazine and the triflufenazine. So just remember the flufenazine, okay, haloperidol and the trifluoroperazine. These are the three drugs for the high potency. Okay, then you have the these low potency drugs, only two, the chlorpromazine and the thioridazine. Okay, most of the drugs has zine in their name, as you can see, except the haloperidol. Okay, zine in their name. So chlorpromazine and the thioridazine are the low potency, rest all are the high potency. Chlorpromazine can deposit in the cornea and the thioridazine can deposit in the retina. So they have their symptoms. In the chlorpromazine, you can get a corneal deposits, and in thioridazine, you will get the retinal deposits. You can remember by T in the retina and C in the cornea. Okay, all these high potency drugs, they have more extrapyramidal symptoms, and the low potency agents have more anticholinergic, antihistaminic, and anti-metabolic symptoms. So for the side effects, all of them can cause a metabolic profile change in the patient. They are all the lipid soluble. They will store in the body fat. Okay, so basically they have a very longer half-life. Okay, they can cause an endocrine dysfunction because of inhibition of what pathway?
Nigrostriatal pathway.
Tuboinfundibular pathway. In the endocrine, they're inhibiting the dopamine receptors by inhibiting the tuboinfundibular pathway. You're having a high level of prolactins. Patient can get a galactoria, oligomenorrhea, and gynecomastia. Okay, they can cause the metabolic syndrome by increasing the patient lipid level, by causing a weight gain, by causing the hyperglycemia. Okay, all these agents having this anti-muscarinic activity. All of these agents can cause the dry mouth, constipation, and if you use them in a patient who is having a history of this glaucoma before, or a silent angle closure glaucoma, these drugs can also cause an acute attack of angle closure glaucoma. Okay,
Okay. Yeah.
they all have this antihistamine activity. That means they can cause a sedation because they can cross the blood-brain barrier easily. They have an alpha blocker activity, so they all can cause the orthostatic hypotension. In the cardiac, they can cause the QT prolongation. Okay, so these are and the ophthalmologic defects we have discussed already. So these are all the side effects with the low potency agents. Okay, mostly with the low potency. For the high potency agents, you mainly has the extrapyramidal side effects, and for that you need to remember the timeline of the patient. Within hour after the use or days after the use, you will get the acute dystonia. We have discussed that already. Treatment include giving the patient benztropine and the diphenhydramine. Within a days of the use, you first get the akathisia, which is a restlessness. We have discussed you will get a sudden urge to move the leg. Treatment include the beta blockers, benztropine again, and the benzodiazepines. You will get the Parkinson's after using them for like 1 or 2 months only. Okay, and you will get a Parkinson's. Treatment again include the benztropine and the amantadine. Okay, within months to years, like 6 months or 7 months later, you can even get the tardive dyskinesia. You will get the chorea-like symptoms and the Tourette-like symptoms. So you will get the motor tics, like the shoulder shrugging, nasal sniffling, okay, or making grunting sounds, or having a coughing sounds, and all these things. Chorea hand you can get. Okay, orofacial features. Sorry, the orofacial tardive dyskinesia will get. The patient will have a pouting movement, right? So these are all the symptoms for the extrapyramidal effects. If you use them in a very too much toxic levels, you can also get the neuroleptic malignant syndrome, right?
Yeah.
Okay, the treatment for the tardive dyskinesia includes the atypical antipsychotics. Whenever you get a patient with the tardive dyskinesia, you need to immediately stop all these typical antipsychotics and you need to switch the patient on the atypical type of antipsychotics like the clozapine. Okay, that was all about these typical antipsychotics. Any doubt, please ask.
When we were
No, thank
treating
you.
When?
patients, yeah, when we were treating Parkinson patients, and it was the whole thing of giving them levodopa or dopamine is only
Yeah,
going to
exactly. You want that dopamine, right? And these drugs are inhibiting the dopamine.
okay. Great. And so those had permanent effects, right? Do these drugs have permanent effects, permanent side effects too?
No, as soon as you as soon as you stop taking these drugs, you will have a reversal of the symptoms.
Okay. Okay, thank you.
So, one of the things you will do first is to stop these agents and give these patients these drugs. They will eventually get normal, okay?
Okay, thank you.
Second are the atypical antipsychotics. They have two things. One, they can block the dopamine receptors, and second, they can also block the serotonin receptors. And like I told you many, many times before, that having a high level of serotonin in the mesocortical pathway is causing a low level of dopamine in this pathway, right?
Right.
So by inhibiting the serotonin in the mesocortical pathway, they're actually increasing the level of dopamine in the mesocortical pathway. And as a result, they can be used for decreasing all these negative symptoms of the psychosis, right?
Yes.
And you get a positive symptoms of the psychosis because of a high dopamine in the mesolimbic pathway. So these agents can inhibit the dopamine in the mesolimbic pathway. So that means the atypical antipsychotics can inhibit both positive as well as the negative side effects. Positive as well as the negative symptoms of the psychosis, right?
Yes.
So 3, 4 agents, you must remember the name of them. Okay, one is the aripiprazole, second is the clozapine. I will tell you specific thing about all these drugs. Okay, olanzapine, quetiapine, risperidone, and the ziprasidone. You must remember only these 5, 6 agents: aripiprazole, clozapine, olanzapine, quetiapine, okay, the ziprasidone, and the risperidone. Okay, now the use again: the schizophrenia, bipolar disorder, okay, OCD, anxiety, depression, mania. Okay, they are the first line therapy for the acute mania. Tourette syndrome. Whenever you get a patient with the Tourette syndrome or the target dyskinesia, you will always use the atypical antipsychotics, right? Clozapine you only use whenever you get the treatment-resistant schizophrenia. You have used all of these agents, yet the patient is still having the episodes of the psychosis. Then only you will use the clozapine because it has a very high side effects. Okay, it can cause the hyponitro sorry, and this drug can cause a neutropenia. Okay, so while giving the patient clozapine, you always need to monitor the neutrophil count. Okay, this drug can cause the agranulocytosis. So measure the WBC or the neutrophil count always, right? Second, whenever the patient is having suicidality also, you can use again the clozapine. Okay, olanzapine, okay, and the clozapine, they can cause the obesity. Okay, very important to know. Risperidone can cause this hyperprolactinemia. Most, the most common side effect, or you can say uh, this hyperprolactinemia is most commonly caused by the risperidone, a very high potency drug that can cause that has a very high potential of causing the hyperprolactinemia. Okay, the risperidone. Third one is the ziprasidone. Okay, the ziprasidone is the drug in the psychotic drugs that can cause a QT prolongation. This is the most common drug which can cause the QT prolongation. Okay, and yeah, that's all about it. So remember these specific things about all these specific drugs. Okay, and remember the use and all the side effects. Mostly they will ask you the side effects of these drugs. Okay, they will ask you if you're giving the patient clozapine, what do you need to do later. Check for the WBC count. If you're giving the ziprasidone, check for the ECG regularly. If you're giving the risperidone, check for the all these prolactin levels, right? If you're giving the patient clozapine, olanzapine, check the body weight or the BMI of the patient regularly. Okay, and because these drug can increase the BMI of the patient, that's why the clozapine and the olanzapine can be used for the treatment of anorexia nervosa also, to increase the body weight of the patient, right?
Yes.
So, olanzapine, clozapine used in the patients with anorexia nervosa who fail to weight gain despite the psychotherapy. And the all agents have a very less EPS side effects. Okay, very important. Any doubt on the atypical antipsychotics?
No, thank you.
So these are the important side effects. Okay, in the sequence you will get them: extrapyramidal, the acute dystonia, akathisia, then the Parkinson's, and finally the tardive dyskinesia. This is the order or the timeline you will see. Then comes the lithium. You will use this drug for the bipolar disorder. Okay, and it causes the formation of the inositol monophosphate. Okay, by inhibiting the phosphoinositol cascade. This is the mechanism of action of the lithium. Okay, uh, it is used in the treatment of the bipolar disorder, especially if the patient is having a maniac dominant bipolar disorder, right? And used to treat the acute maniac episodes. That's why side effects are very much important. This drug can cause either the this drug can cause the hypothyroidism mainly. Okay, this drug can cause the polyuria because it can cause the nephrogenic diabetes insipidus by inhibiting the receptors of the ADH. This drug can cause the Epstein anomaly if the mother uses this drug in the pregnancy. It has a very narrow therapeutic window, so you must look for the levels of this drug regularly. Okay, this drug is almost exclusively excreted by the kidneys. So any drug which decreases the blood flow to the kidney, that means all these diuretic agents, all the ACE ARBs, NSAIDs, which compete for the excretion. All these agents can cause the lithium toxicity. In the lithium toxicity, you will get all the GI symptoms, nausea, vomiting, and the CNS symptoms like the neuropathies. You will see confusions, lethargy, ataxia, tremor, seizure, right? These things will be seen. With the long-term therapy, you can also get the tubointerstitial nephritis with the lithium. Okay, so low thyroid, heart, insipidus, unwanted movement like the tremors. Think about the lithium. Okay.
The renal complication which you talked about is the same as AIA and the acute interstitial nephritis.
What complication, please repeat it again?
The tubulointerstitial nephritis.
Yes.
Is it the same as AIN, acute?
I couldn't hear you actually. Am I audible to everyone? I think I have internet problems.
No, we can hear you.
I'm
It's
okay.
fine.
Okay,
Yeah.
so now repeat it again, please. Okay, I will answer it on the WhatsApp. Okay, now comes the busperon, okay, which is a serotonin receptor agonist, and it is specific 5-HT1A receptor agonist, and it is only used for the generalized anxiety disorder. No other use of this drug is there, just the generalized anxiety disorder. Okay, you use this drug as a first line therapy also in the generalized anxiety disorder because it has a very low rate of addiction. Okay, it has a very low rate of sedation and a low rate of tolerance. Okay, so that's why these things, okay, because it cannot cause sedation or addiction or tolerance, this drug is a very highly used drug for the generalized anxiety disorder. Okay, this drug will take time, of course, just like any other antidepressant drug. It will take around 1 to 2 weeks to cause the action. Okay, it does not interact with the alcohol, okay, or the versus in case of barbiturates and benzodiazepines, because alcohol can potentiate their action. So you cannot use benzodiazepines or barbiturates in the alcoholism, while you can use the buspirone for that, right? It is not effective for any panic disorder, for any other disorder, right? Just for the generalized anxiety disorder. It has no risk of dependence or addiction. Okay.
Yes.
Okay, then you have the antidepressant therapies. In all of these cases, you want to increase the level of serotonin and increase the level of norepinephrine. All of these agents can either increase the level of this norepinephrine or the serotonin or both. They all have a different mechanism of action, of course. For example, the SSRIs, SNRIs, okay, and mostly SSRI, SNRS, TCAs, and trazodone, they inhibit the transporters for the serotonin, and as a result, the reuptake of the serotonin will be inhibited. SNRIs can inhibit both the transporters of serotonin as well as the norepinephrine. Similar thing goes for the TCAs. Okay, bupropion can inhibit the norepinephrine transporters, so increase the level of norepinephrine. Metrazepine can inhibit the alpha. Metrazepine can inhibit the alpha 2 receptors. So basically, you guys know that alpha 2 is present in the presynaptic neurons, inhibiting the release of norepinephrine, right?
Yeah.
So by inhibiting the alpha 2 receptors, I'm increasing the release of norepinephrine. So again, our treatment, and plus the metrazepine can also cause the weight gain. Okay, so for the patients who are having a depression with low appetite, these drugs are extremely helpful for them. MAO inhibitors inhibiting the metabolism of my norepinephrine and the serotonin. It is a mitochondrial enzyme. Okay, so these are all the therapies we will use for the treatment of depression. So first you have the SSRIs, okay, the fluoxetine, fluvoxamine, okay, sertraline, citalopram, and escitalopram. Okay, so remember them like a poem or something. I don't know how you will remember them, but fluoxetine, fluvoxamine, citalopram, escitalopram, sertraline. These are the drugs, the SSRIs. They inhibit the serotonin transporters, so inhibiting the reuptake of serotonin in the neuron. They are the first line therapy for most of these conditions we have discussed already: depression, anxiety, OCD, PTSD, premature ejaculation, bulimia, binge eating, panic. In any case, you can use this. Do note, in the phobic disorder, you will use the behavioral therapy only, no pharmacological therapy, right?
Yes.
Okay, and these drugs also takes around 4 to 8 weeks to cause the effect. So after giving the drug, if the patient does not use it because he's not getting any improvement in the symptoms, you need to encourage the patient to continue the use up to a month, because these drugs will only show effects after a month only. Okay, so you need to encourage the patient to take the drugs for at least 4 to 8 weeks before having any significant improvement. Adverse effects include serotonin syndrome. They can also cause a sexual dysfunction. Okay, so whenever you get a sexual dysfunction like the anorgasmia or the decrease in the libido, you need to stop these agents and give patient other atypical antidepressants, which we will discuss later. Okay, overdose again can cause a serotonin syndrome. We will get autonomic instability, seizures, myoclonus, hyperreflexia, diphoriasis, diarrhea, like we have discussed before. Then you have the SNRIs. Only two drugs you must remember: the valnofexine and the duloxetine. Okay, these drugs can also be used for the neuropathies like the diabetic neuropathy. Other than all the uses of SSRIs, okay, SSRIs plus the diabetic neuropathy, these drugs can be used. Okay, or other neuropathies also. Whenever you got a peripheral neuropathy, you can use the SNRIs, especially the venlafaxine. Okay. Duloxetine can also be used for the fibromyalgia, as we have discussed previously. You will get a muscle pain, you will get a depression and multiple tender points, right? Remember fibromyalgia?
Yeah.
So duloxetine can also be used for that. Okay. Then you have tricyclic antidepressants, and you can remember them by, like, they are all the prime drugs. Okay, like the imipramine, dacipramin, the clomipramine. So they are the prime drugs, right? And one thing remember, that is the amitriptyline. So amitriptyline, nortriptyline, and the prime drugs, imipramine, dacipramin, clomipramine, they are the tricyclic antidepressants. They inhibit both the uptake of serotonin and the norepinephrine. Okay, they can be used for the MDD. Okay, they can be used for the peripheral neuropathy, which we discussed already, I think, in the neurology. Remember
Yeah.
the neuropathic pains we have discussed, SNRIs, TCAs, and all this, the gabapentin, pregabalin, and the casapsin cream. Remember?
Yeah.
So we can use them for the peripheral neuropathy. We can use them for the neuropathic pain, of course. These drugs are also used for the migraine prophylaxis. And rest in all conditions, they are they are a second line therapy, not a first line therapy, because of a very high side effects, right? Adverse effects, you must remember, they all have an antihistaminic effect, anti-alpha effect, anti-ACH effect. So with the antihistamine effect, they can cause a sedation. With the alpha blocking effect, they can cause the postural hypotension or the orthostatic hypotension. With the anti-muscarinic effect, they can cause the atropine-like symptoms. They are anticholinergic. So the side effects include tachycardia, tachypnea. Okay, the urinary retention will be there, dry mouth will be there. Okay, and they can cause anticholinergic side effects, which are all that before. They all can cause the QT prolongation, a very important thing you must remember, QT prolongation. Okay, so convulsions, coma, and cardiotoxicity. For the treatment, you need to give the patient sodium bicarbonate, okay, because of a sodium channel inhibition. Okay, confusions and hallucinations are also very much common in the elderly if you give these drugs to an elderly patient, and that's why these drugs are contraindicated in the elderly patients because of their anticholinergic actions. They can also cause a glaucoma in them, right? So avoid these drugs in the elderly patients. Any doubt?
No, thank you.
So just think about the antihistamine, LT alpha, and anti-muscarinic, these three, and you can always know what side effects these drugs can have. Then come the MAO inhibitors, and these are the trinseploprem and the phenelzine. Okay. So trinseploprem and the phenelzine, these two drugs you must remember. Rasagiline and salogeline are the MAO B inhibitors. These two drugs, they are the MAO A inhibitors. MAO A are used for the depression, okay, and MAO B are used for
Parkinson's.
Parkinson's. Okay. So they increases the level of neurotransmitters like the norepinephrine, serotonin, and the dopamine. They are useful for the atypical type of depression. And does anyone remember the definition of this atypical depression?
Laden paralysis will be there. And
Yeah. We are saying one is a
and
latent paralysis.
and probably there will be no functional impairment. I don't remember.
You have four, other than depression, you have four things other also. One is the mood reactivity. Second is the hyperphagia. Third is the hypersomnia. And fourth is the latent paralysis, right?
Yeah.
So these are the features of the atypical depression. You must use these agents in them. Anxiety, Parkinson's, rasagiline, salogeline will be useful. Okay. After you give the patient MAO inhibitors, and now if you want to switch the patient back to the SSRIs, you must need a washout period of at least 1 or 2 weeks. In that scenario, if you immediately switch the patient from MAO to SSRIs, patient can have a serotonin syndrome because you're having a MAO inhibition, right? And so you already have a high level of serotonin. Apart from that, if you give the patient SSRIs, you can have a high level of serotonin, right?
Right.
So you cannot immediately switch the patient back into SSRIs. You need a washout period. In that period, MAO will regenerate. Only then you can give the patient SSRIs. I will send the recording today, okay? All the last 3-4 lectures, I will send the recording today. Okay.
Okay, thank you.
Okay. With other agents also, you can have a serotonin syndrome like the St. John's wort, SSRIs, TCAs, linezolid, dextromethorphan, meperidine, right? And the tramadol, right? So all these agents are very much contraindicated if you use them. Okay. And if you're using the patient MAO, if you're the patient on the MAO inhibitor therapy, you need to always avoid the cheese foods because of a hypertensive crisis, because they can cause the because they can increase all this tyramine in them, right? The tyrosine, right? So avoid all
Yeah.
these cheese, all these cold drinks, all these pizza, burgers, alcohol also, right? Avoid these things because of a hypertensive crisis. So hypertensive crisis, serotonin syndrome, okay, and the 2-week washout period. These are the important things you must remember for the MAO inhibitor therapy. Any doubt?
No, thank you.
Then you have the atypical type of antidepressants. Okay. The first one is the bupropion, which is an inhibitor of the norepinephrine and the dopamine. Not the serotonin, but the norepinephrine and dopamine. Okay. The bupropion is mostly used for the smoking cessation also. If you give a patient SSRIs and they got a erectile dysfunction, in that case, you will always switch them to the bupropion first. Okay, not the TCAs or not the MAO because they have a very high side effect. Okay, with the SSRI patient who is having erectile dysfunction, you will give them the bupropion first. You cannot use them for the anorexia nervosa or the bulimia nervosa because of a seizures problem. Okay, so the important thing is to remember that give the patient who developed the sexual dysfunction because of SSRIs. Smoking cessation should be also be used, and they are the inhibitor of dopamine and norepinephrine, not the serotonins. Then comes a mirtazapine, which is an alpha-2 antagonist, and it is used to increase the weight in the patient having the MDD or the anorexia nervosa. Okay. Then you have the trazodone. For the trazodone, you must remember you will always give them for the sedation. Okay, those depressing patients who cannot sleep, you will give them the trazodone because it's a high potency inhibitor of histamine receptors. So they can cause a sedation. Apart from histamine, there are also adrenergic blockers, alpha-1, so they can cause a postural hypotension. They also block the serotonin, so they can cause a priapism, because you know that serotonin causes vasospasms, right?
Yeah.
So by inhibiting the serotonin, it can cause the vasodilation, and that can cause a very painful ischemic priapism. Okay, so priapism, postural hypotension, okay, and sedation. These are the thing you will remember for the trazodone, and that's why it will used in the patient having an insomnia mainly. Okay. Then you have the vernaculine, which is a nicotine receptor partial agonist. Okay, it is mainly used for the smoking cessation. Okay, other agents like vilazodone, okay, or the vortioxetine, okay, these drugs are also inhibit the serotonin reuptake. Okay, and especially the serotonin 5-HT1A type. Okay, just like any other serotonin agent. So nothing much important, just they can cause a headache, diarrhea, nausea, anticholinergic effect. They all can cause a serotonin syndrome, just like with any other agent, right? Nothing much important about these two agents. Just remember for the vernaculine, it is used mainly for the smoking cessation. Propapion is smoking cessation. Apart from that, both can be used for the depression. Trazodone mainly used for the sedation. Okay, they can cause a ischemic priapism, especially true with the all these sickle cell anemic patients, especially true for the sickle cell anemic patients, right? Because they can clog the blood vessels. Mirtazapine for the weight gain, especially in the depression. And yeah, that would be all on this page. Any doubt?
No, thank you.
Then you have the opioid detoxification program, and for that you need to first give the patient methadone because it is a very long acting opioid, so patient require less doses. Okay, they will take one dose, and after after a very prolonged period of time they can use another dose, not like a normal opioid which they use daily. So for the maintenance you will use the methadone to decrease the cravings of the patient for the opioids. because it is a longer acting opioid agonist. It is metabolized by the P450. So if you are a patient who is on a P450 inhibitor therapy, any drug who is inhibiting the cytochrome P450, it can cause a toxicity of the methadone. Like any other opioid a toxicity, you will get a similar symptoms. You will get all the constipation, respiratory depression, CNS depression, right? CVS depression like the bradycardia, hypotension, respiratory will be less like 10 or 12 only, right? Drowsiness will be seen, and constipation will also get. So long-term maintenance therapy, think about the methadone to decrease the cravings and the withdrawal symptoms because of a longer half-life. Then you have the buprenorphine, and it is a partial agonist used to prevent the relapse. You cannot use this agent in an acute opioid patient who is in acute opioid therapy. After you stabilize the patient, only then you can give these agents to prevent the relapse. Because if you give them a patient who is on a full agonist therapy, it will cause the precipitation of the withdrawal, right? No,
How will that happen?
because it is a partial agonist. In the presence of full agonist, it will act as an antagonist, right?
Right, yeah.
So cannot used in a patient who is on a full opioid therapy, full agonist therapy. If it is a patient who is on a pain relief medication, analgesic like opioids, you cannot give the patient buprenorphine. It will cause an acute precipitation. Only used once the patient is kind of stabilized, and you now need these agents for the maintenance, like the methadone. Instead of methadone, you can give the patient buprenorphine also. Now, other agents are mainly used for the acute therapy, this naloxone. Okay, whenever you got a patient with an acute opioid overdosing, you will give the patient naloxone to block the receptors of the opioids. It is a short-acting agent. That's why you need a continuous infusions of the naloxone. Okay, it would be a case of a patient who come to your department with the opioid overdose. You give them the naloxone, and after like 1 or 2 hours later, after giving the naloxone, patient have an improvement of the symptoms. But again, after 1 to 2 hours later, the patient started having all these CNS depression, low respiratory rate, okay, low heart rate, low BP, constipation. Why? Because you need multiple infusions of the naloxone because it is a short acting agent. It could be given IM or IV or a nasal spray also. Prevent opioid overdosing with that. Okay. Then comes a naltrexone. You need this to after you kind of block all the receptors for the opioids, you stabilize the patient with the naloxone. After that, as an outpatient program, you can use the naltrexone in the patient. Okay, after the patient is detoxified with the this naloxone, you can give the patient naltrexone for the maintenance. You uses the buprenorphine and the naltrexone as a combined therapy, okay, to prevent the opioid addiction, okay, because naltrexone will inhibit all the receptors, and buprenorphine can cause a partial agonist effect, right? A weak efficacy drug, okay,
Yes.
and it is a long-acting drug, so that's why you will need a very few doses, unlike the naloxone. You can use a naltrexone also to prevent the alcohol, okay, to decrease the cravings of the alcohol. You will also use the naltrexone. Other drug that you can use to decrease the cravings of the alcohol is the acamprosate, which we have discussed already. It is the NDMA receptor blocker, modulator, you can say. Okay, it is a mainly a blocker. Okay, just like your ketamine, just like your phencyclidine. Okay, it is a blocker of the NDMA receptors, acamprosate. Disulfiram is not a first-line therapy; it is a second-line therapy. Okay, it is used to discourage the drinking. Okay, it cannot decrease the cravings. It is used to discourage the drinking because after drinking the alcohol, if this is a patient on the disulfiram therapy, they will have so much side effects. Okay, so if the step one asks you the drug which can decrease the cravings of the alcohol, either the naltrexone or the acamprosate. If they ask you a drug to discourage the drinking, you will give the answer disulfiram. Similar thing goes for the smoking. If they ask you, a treatment for the patient, okay, to satisfy the cravings, if they ask you to satisfy the cravings, instead of smoking, you can give the patient nicotine patch, the gum, okay, the patch or anything. If they ask you to decrease the cravings of the smoking, what thing you can give? You can give the patient these two drugs, bupropion or the vernaclin. Okay. So just look for what they're asking you. If they're asking you to satisfy a patient with other drug, you can give, in case of my alcohol, sorry, in case of my smoking, you can give the patient nicotine patch or gum. If they are asking you to decrease the cravings, you must use the vernaclin or the bupropion. Similarly, for the alcohol, if they ask you to discourage the drinking, disulfiram. If they ask you to decrease the cravings, you can give the patient acamprosate or the naltrexone. Is that okay?
Yeah.
Okay, so that about the all this psychiatry. We're finished with it.
Thank you.
Okay, any doubt? If there is, please ask in a psychiatry or any of the page.
You were talking about interstitial nephritis in lithium.
Yes.
Yeah, so basically that is acute interstitial nephritis.
Actually, it happens after chronic therapy only, not in the acute therapy. Okay, it is similar. The patient will have the same symptoms just like with any other drug. Okay, but it only happens
Okay.
after chronic use.
Okay. And it is called tubulointerstitial nephritis.
Yeah, tubointerstitial nephritis, because it causes the inflammation in the tubules as well as in the interstitium.
Okay, all right. Thank you.
We will discuss that later on, but in the renal section in the upcoming chapter, we will discuss all these things. So just wait for it.
Okay. Thank
Any
you.
more doubt? Any more doubt? Anyone?
No.
Okay, so we are done with the psychiatry now.